Bonjour, good morning, and welcome to the opening session of Wednesday. I had to check my days. I'm Heatherly Bailey from the United States with my esteemed colleague Matteo Passetti from Genoa, Italy. And we are pleased to start the session on COVID-19, what also applies to bacterial sepsis. Our first speaker this morning is John Marshall from St. Michael's Hospital in Toronto, speaking on what COVID-19 has taught us about sepsis. Welcome, John.
Thank you so much, Heatherly. I think the answer to this is a little bit like the answer that Mao Zedong is reported to have given when he was asked about the French Revolution. Too early to tell. But I think also that we have learned quite a bit about sepsis, about ARDS, about critical illness, and a lot of those lessons are really in the process of being synthesized and the consequences of them sorted out. Very early on during the pandemic, there were a number of opinion pieces talking about whether or not COVID-19 was sepsis. There was even concern that we were ignoring sepsis because of our focus on COVID-19. Similarly, was COVID-19 like classical ARDS, or is it somehow different? And I think what they kind of underlined is that we didn't really know what sepsis is and what ARDS is, and that there really is no classical sepsis, there is no classical ARDS, that they are probably manifestations of a similar kind of process or multiple different processes. And so I think in this regard, COVID-19 has given us a bit of a jolt in thinking about how we think about critical illness. Now, clearly, by the definitions, our current definitions for sepsis, life-threatening organ dysfunction caused by a dysregulated host response to infection, COVID-19, in its most severe forms, is sepsis, by definition. But the other thing that was apparent is that here we had, if we accepted the notion that this was an example of sepsis, we had a disease state that might be more homogeneous than the way we've been thinking about sepsis before. We had a single organism that was responsible for the syndrome. We knew a lot about how that organism caused disease through its interactions with the ACE2 receptor, and often these diseases arose in people who had relatively few comorbidities, certainly not necessarily, although it varied from one venue to another, life-limiting illnesses or illnesses at the end of life. But even with this, we still see the same problem that the host response is heterogeneous. This is very beautiful work done by the Genomic Consortium led by Kenny Bailey in Edinburgh, where they did GWAS analyses of genes that were expressed in patients with COVID-19. And they were able to identify some particular genes that were associated with severity in COVID-19. So even within this apparently homogeneous process caused by a single microorganism or a single virus, there is heterogeneity at the level of the host response. The other thing I think that we've learned about COVID-19 is that while it may be different when it first starts, when one first becomes infected with the organism, once you are in the ICU, you begin to look very, very much like all ICU patients look like. You develop that state of critical illness. And so this is a paper out of Thailand that showed patients with severe COVID-19 in the ICU developed endotoxemia, capillary leak syndrome, all of the things that we see in patients with sepsis caused by other microorganisms, in patients with ARDS, in patients with multiple trauma. It's the clinical phenotype of critical illness. So I think COVID-19 is challenging us to rethink how we define the various entities that cause patients to become critically ill. We have had some real successes. It's been 30 years of research in evaluating therapies that target the host response, where we had essentially no useful information come out of large clinical trials. And then in a matter of mere months in COVID-19, the basic hypothesis that one could independently target the host response response was validated. So this first happened with the recovery trial. These results were reported a mere 3 months after the trial was approved and the first patient was enrolled. But what the investigators in recovery showed was that treatment with dexamethasone could save lives of patients with severe COVID-19. Not mild COVID-19, but severe COVID-19. And in synthesizing these data across multiple different trials, and interestingly, these data were synthesized while the trials were still ongoing and before they'd been published in a prospective meta-analysis, we could see that the effect of corticosteroids was similar across geographic regions and across steroid preparations. So hydrocortisone as well was effective. So that was a big step forward, and just at this meeting, we've now seen that corticosteroids are beneficial in patients with severe community-acquired pneumonia. One can look at the history of corticosteroids, which goes back as long as antibiotics do, and has been as controversial as anything else in critical care. And it does look like coming out of COVID-19 that we're now beginning to get some clarity on the role of steroids. And it's interesting here that it seems to be in patients not with the diffuse generic concept of sepsis, but in those patients who have severe infections. Those are the patients that benefit from corticosteroids. We've also seen the first evidence that targeting the host inflammatory mediator response can improve outcomes in patients with COVID-19. Interleukin-6 receptor antagonists, again, across multiple different trials, more than 11,000 patients included in meta-analyses of this, and both tocilizumab and sarilumab can improve survival and shorten the duration of organ dysfunction in critically ill patients. I'm going to say a little bit more about this later, but one of the key things we've learned in COVID-19 is that we can do clinical trials in a much more efficient way. And REMAP-CAP has really been the signature trial for critical illness. We've studied multiple different interventions and really begun to plot out the landscape of what works and, as importantly, what doesn't work in severe COVID-19. So antiviral agents are, if anything, detrimental, but corticosteroids and IL-6 receptor antagonists are beneficial. Heparin seems to not be beneficial in severe disease, but beneficial in moderate disease. And more recently, we have generated information that aspirin is effective in saving lives when you measure it at 6 months after treatment, that ACE2 inhibitors and angiotensin receptor blockers are probably harmful in COVID-19, and that vitamin C, compatible with the results of the Lovett trial, is also harmful in patients with severe COVID-19. So this is astonishing, really. In the matter of really 2 years, we've generated more information about adjuvant therapy for critical illness than we ever had in the past. Recovery's also seen some of these things. They've also shown that JAK inhibitors benefit patients with severe COVID-19, and have also seen that a lot of the popularly touted antiviral drugs are ineffective or potentially even harmful. Another thing that's become apparent, though, in COVID-19 is that heterogeneity in treatment effect is present, and particularly heterogeneity based on disease severity. So corticosteroids work in patients with severe disease, heparin in patients with moderate disease. IL-1RA may work in patients with evidence of a more inflammatory phenotype, and again, baricitinib is most effective in patients with severe disease. I think one of the really interesting insights for those of us who've kind of been looking to mouse models of cecal ligation and puncture or endotoxemia as the place where we find potentially promising drugs for sepsis is the fact that rheumatoid arthritis has now emerged as being probably the best almost preclinical model of sepsis. And a number of different things that are standard therapies in rheumatoid arthritis are now being shown to be beneficial in critical illness. Both baricitinib and IL-6 receptor antagonists emerged from the rheumatological literature. And so there's a rich group of potential agents that might be more efficacious than what we've studied in the past. There are some data, for example, that imatinib is potentially beneficial, that TNF is potentially beneficial, perhaps that complement in inhibiting complement C5a may be beneficial. So we're getting a whole new repertoire of new interventions coming up. We're also learning that there are better trial designs to undertake studies where we're trying to find drugs that work in a population of patients. And the trial design that has really kind of moved to the fore in COVID-19 has been the platform trial. The beauty of a platform trial is that you're studying a disease, and so you can study multiple different interventions for that disease, either alone or in combination. You run it until you reach a predefined conclusion for that particular intervention. You can add new interventions onto the platform. And so a platform trial is really a perpetual clinical trial that is much closer to what happens in clinical practice. And I think it's a potentially potent tool to expedite the evaluation of new therapies for sepsis. We've also learned, as I alluded to earlier, that the host response to critical illness in COVID-19 is variable, but that we are developing techniques to understand where that lies. Ewan Gallagher presented some beautiful work that has come out of the multi-platform trial, looking at this difference between severe and moderate state in the response to heparin. Not entirely clear what the underlying biology is here, but it is becoming clear that there is an interaction between disease severity and the potential to gain benefit from intervention with an anticoagulant. It may simply be that the harms are greater if you're less ill, and therefore the net impact is less. But we are beginning to start to think about critical illness not so much as a series of syndromes, but as syndromes that share biologic commonalities across these syndromes, and that in targeting the host response, we want to target those biologic similarities, not the initial syndromes we used to describe them. This is a paper that we had in Nature Medicine last year that develops that concept further with respect to COVID-19. And just recently, we had a roundtable prior to this meeting to explore this issue of moving to resolve heterogeneity of treatment effect and how we might do that. The schematic here, I won't go through it in detail, but is from our Nature Medicine paper, suggesting that if you start with this heterogeneous group of syndromes, we have techniques, machine learning, that can find the commonalities in them. Then we could group those patients by their commonalities and study them on platform trials, and that could very much speed up the process of understanding what works and what doesn't work. Finally, we've learned that success, that global collaboration is not only possible, but essential if we really want to do things quickly and have results that are generalizable. REMAP-CAP was actually a product of the last pandemic, the H1N1 pandemic, specifically set up so that the architecture was in place for the next pandemic. And it had turned out to be effective. We've been able to secure support from multiple different funders to add new interventions as more was learned about the course of COVID-19. And so I think that's been effective. Governments have begun to understand that there's a role to be played for high-level coordination of research activities. In the United Kingdom, certain trials were mandated. We kind of got away from this hodgepodge of the person who's paying the most money is the trial that you recruit your patients to. And so recovery and REMAP-CAP were prioritized for patients with hospitalized patients and patients in the ICU, respectively. So all of this, I mean, things move very, very slowly in medicine. And it's one of the things you learn as you get older. It's not going to happen next week. It's not going to happen next year. Not going to happen in the next decade necessarily. But this is no different from any other disease process that really has made inroads into developing sophisticated models of adjuvant therapy and multidisciplinary multidisciplinary therapy. In cancer, there were congresses held back as far as 1906 and on a semi-regular basis from then on to talk about how people could work together at an international scale to better study cancer. And so it was in 1932 or 33 in Madrid, so this is almost 30 years later, that the International Union Against Cancer was established, and that has really been the body that's driven staging for cancer and has made possible both adjuvant chemotherapy and specific therapies that target some of the distinct biologic processes that underlie cancer. So we still have a long way to go, but I think COVID-19 has definitely sped up our course on that way. It's really opened the door to, I think, the next phase of research and the next phase of potential treatments in critical illness. Thanks very much.
Thank you, John. We have a group discussion at 9:15, so we'll take our next speaker.
So it's my pleasure to introduce Dr. Djillali Annane from the Hôpital Raymond Poincaré, University of Versailles in Paris. He's going to talk about how different from bacterial sepsis, please.
Good morning, dear chairs, dear colleague. Indeed, in the next 9 to 10 minutes, I will try to share with you some data we collected in Paris and Great Paris area during the 2 years of pandemics, looking at the specific issue of is COVID-19 like a bacterial sepsis. My declaration of interest. So, as John said, looking at the third international consensus for the definition of sepsis, there is no doubt that actually the phenotype we are seeing for patients with COVID-19 meets all the criteria of the sepsis redefinition. We have an infection, we have a pathogen, we have the site of infection, the infection causes organ dysfunctions, and in the sickest patients can cause sepsis and septic shock. So definitely we knew and we understood at the very beginning of the pandemic that COVID-19 might be a form of sepsis and septic shock. And indeed, even the timeline of the disease is very similar than the one we can observe with a patient with pneumococcus pneumonia, for example. Then, looking at the lab values, numerous studies investigated the inflammatory profiles from these patients at the very beginning, again, of the pandemic, and again, highlighting that COVID-19 was characterized at the molecular level by intense inflammatory response, and that there was some correlation between the level and the degree of the inflammatory response, as illustrated by the level of cytokines or complement pathway activation, parallel the severity of a clinical phenotype. Likewise, by comparing with retrospective historical cohorts of patients with ARDS or bacterial sepsis, looking at cytokine levels, there was evidence for similar patterns in patients with COVID-19, in particular those admitted to the intensive care unit as compared to patients with ARDS and or sepsis from bacteria. And indeed, like you at our bedside, patients with critical COVID looks pretty much like any patient with bacterial sepsis. So we looked, we used our institution data warehouse. So it has 11 million patients from 39 hospitals. And we abstracted data by the end of September 2022. We screened the patient within the database, focusing on adults admitted at least 2 weeks before the start of the first wave in France, at least in Paris. and discharge before the end of the year 21. I have to mention here that since now 2019, the national plan for the fight against sepsis in France has established a formal process for coding sepsis. So in the database, the sepsis is coded in a standardized manner in every hospitals. So we use these coding as per it is state mandated now in France, and we excluded pregnant women as well as patients who were still hospitalized. So during the 2 years, there were 1,217,952 patients that were tested for COVID suspicion. There were 18,754 patients with sepsis. So, and you can see that there were some patients that we excluded for pregnancy or in patients for whom there were still inconclusive data about the COVID status, and some patients for whom we could not clarify the way they were managed. And so that remained 1,875 patients. One can see that about 37% of patients had severe COVID, and 63% of patients had bacterial sepsis. And you have also, that's my academic biases, the proportion of patients who are receiving corticosteroids for COVID disease or for bacterial sepsis. And unsurprisingly, the patients were more likely to receive corticosteroids where there were COVID patients rather than bacterial sepsis. This is the COVID positive admission over time, highlighting that most of patients were critical patients were admitted during the first wave. You see that the second wave was characterized by much less sicker patients, so much less critical COVID-19, only 15%. And the beginning of 21, as you remember, the Delta-driven wave came, and it resulted in at least as many critical COVID-19 patients than during the first wave, and this in spite of all the therapeutic availables by this time, highlighting that the Delta variant was really a disruption in the evolution of the pandemic. So what is a comparison? How the patients did compare themselves? And here I must say that we were a little bit surprised, because indeed there is absolutely no difference in terms of demographic characteristics, age or gender, about the proportion of patients with comorbidities. It might be the patient with COVID positive might be more likely to have acute hypoxemic respiratory failure, and also more likely to have multiple organ failure than the patient with bacterial sepsis. Focusing on the comorbidities, no difference at all with regard of a proportion of patients with hypertension, COPD, diabetes, or coronary artery disease. Very similar population. Looking at lab values, and focusing in particular on organ dysfunction and indicators of inflammation, one can see that renal function, whether assessed by creatinine level or glomerular filtration rate, were completely comparable in between bacterial sepsis and COVID positive. Likewise for bilirubin levels, likewise for D-dimers. The leukocytes were slightly, but clinically not relevant, slightly higher in the bacterial sepsis. And look at CRP, procalcitonin, and even interleukin-6 level were globally similar in patients with critical COVID than in patients with bacterial sepsis. Again, the main way they were managed, highlight that the patients with COVID positive were more likely to receive corticosteroids, more likely to be on respiratory support, more likely to have invasive mechanical ventilation, and also has a longer length of stay. And the outcome is interesting because one can see here that the death rate at 28 days were significantly higher in patients with COVID positive than patients with bacterial sepsis. Likewise, at 1 year, the mortality was also significantly higher in patients with COVID positive compared to patients with bacterial sepsis. And that in spite of all I said before, in spite of same age, gender, same proportion of comorbidities, and same degree of organ dysfunction. That's interesting because that means that it's something different that we did not pick up with the clinical phenotype that drives mortality in critical COVID patients when compared to bacterial sepsis. And by the opposite, one can see when looking at the readmission of patients who were discharged from the hospital, there were many more patients readmitted at 3 months and 1 year in the bacterial sepsis group as compared to the COVID positive group. And the mortality in men and women across age was completely similar in this population. Looking at prognostic factors, we got exactly the same prognostic factors: age, comorbidities, being on invasive mechanical ventilation, having multiple organ dysfunction. Not surprising, but what was surprising is that it was exactly the same odds ratio for patients with bacterial sepsis or COVID-positive patients. So to conclude, if deregulated immune response to SARS-CoV-2 drives lethality in COVID-19 patients like in patients with bacterial sepsis, when compared to bacterial sepsis, patients with COVID-related sepsis had more often acute hypoxemic respiratory failure, more often requirement for respiratory support and invasive mechanical ventilation. They stayed longer at the hospital. They were more likely to die at 1 month and 1 year, and the survivors were less likely to be readmitted than patients with bacterial sepsis. Thank you very much for your attention.
So thank you for your presentation. So could you please remain there because we decide to do the discussion after each talk in order to allow the possibility for speakers to go eventually in other rooms. So
maybe you want also to take questions?
Yes, exactly.
Please.
We ask also,
Dr. Marshall.
just a very simple question as an infectious disease doctor. When you mention bacterial sepsis means a very broad spectrum of different diseases. So my question is, did you find any particular difference inside of the bacterial sepsis, gram-negative, gram-positive, eventually Pseudomonas, Acinetobacter, Staphylococcus aureus, because as you know, are totally different, inside of bacterial sepsis. For us, bacterial sepsis doesn't mean anything.
Yeah, for me, it does mean something, at least. But, there was no surprise. The main pathogens were gram-positive pathogens. Community-acquired pneumonia was the main source of infections. And of course, in the different models, we included as a confounder the type of pathogens, the site of infection, and they were not significant modifier of the outcomes.
Are there any questions from the audience for either Dr. Annane or Dr. Marshall?
So I want to go back to the Marshall presentation. So regarding, so you mentioned the convalescent plasma. So I am from a country in which there was a lot of political debate about the convalescent plasma. So could you please clarify the potential role of convalescent plasma in serious cases and in the prevention of development of severe form?
Yeah, it's an excellent question because that story's not been told yet, the full story of convalescent plasma. In REMAP-CAP and in recovery as well, there was no overall effect when patients were treated with convalescent plasma. And you have to remember, number one, that's a heterogeneous population, and number two, it was early on in the course of the pandemic before immunization. There was in REMAP-CAP a subgroup effect, and that was that patients who were immunocompromised seemed to have benefit when they were treated. And so that particular subset of patients is currently being evaluated in REMAP-CAP. And using a somewhat more sophisticated approach, we're using patients who have both been immunized and had the disease in the past and taken convalescent plasma where we know the titers of the antibodies, and using it in a population of patients that's immunocompromised. So there may or may not be a signal there, but I think it's a great example of how a trial can actually learn as it goes forward, and also perhaps the risk of rejecting things before you really understand them.
John, another question for you. You gave a wonderful overview of what COVID-19 has taught us, many positive things and many negative. If you had to choose one item that we learned from this whole process, what do you feel has been the most beneficial?
I think it's that we're better when we work together. I think there really was an inspiring global response to COVID-19. Some of it kind of degenerated with a lot of the politics that came up, the vaccine hesitancy and that sort of thing. But I think this is really unprecedented in the field of biomedical science to see this kind of global collaboration. And I think that's really the lesson we have to learn, and that's the aspiration we have to take forward.
Anyone from the audience have any questions? Dr. Annane, a quick question for you. You had an amazing amount of patients, and your review of comparing COVID sepsis and bacterial sepsis. Why do you think there is such a difference at that 90 and 1 year out, where one group needs to be readmitted and the other does not?
Yeah, we were really surprised by this because not only the population were comparable in terms of age, gender, comorbidities, organ dysfunction, but also for COVID-19 we did have treatments, or for bacterial sepsis except for antibiotics. And in some patients, we didn't have treatment. So we expected the opposite. And so we are now looking, because we have access to transcriptomic data, to see whether there are at the molecular levels some explanation or hypothesis to understand a little bit more why these patients with COVID-19 were dying more frequently than the bacterial sepsis patients.
Thank you both very much. We'd like to invite our next speaker, which is Beverley Hunt from Guy's and St. Thomas National Health Service Foundation Trust, King's College University, London, UK.
Well, thank you very much. I have been asked to talk about thrombocoagulopathic mechanisms and the differences in COVID and bacterial sepsis. I don't have any conflicts of interest apart from my membership of living guidance for NICE and for the WHO. I just want to echo John Marshall's comment about the value of the platform trials. They are totally unique and gave us answers very quickly, especially in how we manage COVID-19, and also this incredible heterogeneity of patient response within those trials, which was exemplified by the fact that full dose heparin was beneficial to those with moderate COVID, whereas those with severe only benefited from prophylactic doses. Now, I'm pulling back just to go back to basics, because when we started with COVID, it feels a very, very long time ago, we had messages coming out of Wuhan and China to say, these patients had a disseminated intravascular coagulation. And those early papers that were rushed through were all saying COVID-19 was producing a DIC. And DIC, or disseminated international confusion, which is probably a better way of putting it, we all know about. It's unregulated coagulation activation leading to deposition of clots in places we don't want them, particularly the head and the heart and the kidneys. And when we look at DIC, the number one place in hospital to see it is in the intensive care unit, and the number one cause in the intensive care unit is sepsis. Although if we look globally, it's snake bites that cause more DIC than anything else. And we know from a lot of work that most DICs driven by bacteria are dependent on the cytokine storm activating tissue factor expression on monocytes and causing endothelial cell activation. And this importance of tissue factor in sepsis has been shown in animal models. So if you give anti-tissue factor monoclonals to the baboon model, you don't get the development of DIC. And when you look at patients with DIC, they have high levels of tissue factor antigen circulating. We know in meningococcal sepsis very much something from the past because of our use of the meningococcal vaccine, that the amount of monocyte tissue factor was prognostic for survival. And we have within us variation in TF expression, and that is determinant on outcome in some animal models. When we look at fibrinolysis in DIC, it's switched off, mainly because of upregulation of PI1 from the endothelium. And once again, we have some work which suggests that PI1 polymorphisms will affect outcome. And we know in bacterial sepsis in London, we used to have an ambulance service that would go around picking up all the children with meningococcal sepsis, taking them to one hospital and managing. And they looked at the polymorphisms in the PI1 receptor, and those who had a particular polymorphism where you get very high PI1 levels had the worst outcome. And that is because we are absolutely dependent on fibrinolysis to break down all of those clots that are sitting in head, heart, and kidneys and heal. And so that is one of the reasons why you should never use antifibrinolytics in a DIC, because you need fibrinolysis, endogenous fibrinolysis for healing. So along comes COVID. We are hospitalizing way back at the beginning of 2020, many patients who've got COVID pneumonia. And this is telling us about COVID over time, because COVID isn't just one disease. If you look at these two diagrams, the top shows the deaths in NHS England from COVID over time, and you can see that first wave, wild type, and the second mountain, we've got a little hillock of alpha, and then the bigger hill or mountain due to delta, and then towards the end, we have the little hills of Omicron, where we are managing Omicron in a population that are vaccinated and probably have some immunity due to previous COVID. At the bottom is a heat map of our deaths according to age. So the darker the color, then the more deaths there are, and you've got age up the side. So you can see COVID-19 is a disease in older people, and that the majority of the deaths were those who are elderly. So in those early days, and again with Delta, we saw many cases of venous thromboembolism, and this captures the deaths and the number of cases. This is the Swedish data, and what I want you to look at is the odds ratio of DVT, and you can see for moderate COVID, 20 times background risk, for severe, 30 times background risk. However, when we look at pulmonary embolism, we've got huge risks in the hundreds. And this doesn't hang together because normally with DVT and PE, if you look at the natural presentation, 2/3 will present with DVT, 1/3 with PE. But we've got 100-fold greater numbers of PE. And I think that reflects what we were seeing, because we're seeing two pathologies in the lung. Both will show up on CTPA, and all were counted as pulmonary embolism. So we've got this beautiful model of VTE with COVID, incredible prothrombotic state. They're immobile, we've got endothelial cell activation, so high rates of VTE, but we also, and for many of us for the first time, saw immunothrombosis, which of course we've known about since it was described back in 2013 as occurring in patients with acute respiratory distress syndrome. So the horror of those early days, you'd go to intensive care and people were clotting up their hemodialysis machines. Everybody was trying to organize CTPA. The patients themselves, they might become a little bit hypoxic, and we presumed it was PE, although we now know that COVID can behave in that way. And there was a lot of talk about venous thromboembolism. I went on BBC Radio and talked about it, and some of the horror in my voice about what I was seeing must have hit home with David Hare, who's one of our playwrights, and he wrote a play about COVID-19, and Ralph Fiennes, also known as Voldemort, played, basically, it was a monologue, and every night he'd talk about the horrors of deep vein thrombosis and pulmonary embolism in COVID. Very good patient and public education. And the part of the horror was this amazing prothrombotic state we saw. So we're all taken aback. This was not disseminated intravascular coagulation. What we are seeing is a profound inflammatory response, those very, very high fibrinogens. One of the posters yesterday had a fibrinogen of 16 grams per liter from those early days of COVID. So this is wild type and Delta. We're not seeing this now, and we are not seeing these high rates of VTE. The other issue is that the fibrin clots that are formed in COVID, they are not the same as normal clots. So this is some very nice work out of Pittsburgh. So when you make a clot normally, the fibrin strands are wildly separated, and you can see on the right, in the COVID patient, we've got these dense fibrin strands, and part of the density and the inability of the fibrolytic system to get in and dissolve them is because there's an intense amount of salicylic acid sitting attached to the fibrin molecules, and the bottom slide beneath the COVID-19 is the use of an enzyme to remove the salicylic acid. So you can see much of that density relates to salicylic acid. Then the other conundrum we had was those very, very high D-dimers we saw initially. And we have to remember, and we all know, D-dimers are an expression of inflammation and coagulation. And in actual fact, the data that came from, it's actually a Wuhan paper early on, showing that the D-dimer levels are increased in all cases of acute respiratory distress syndrome. It's just really forgotten, or maybe some of us learnt it for the first time. So it's a marker of ARDS, and actually the patients themselves have fibrinolytic shutdown. So you have this paradox. The fibrinolysis is switched off. This is a TEG from a COVID patient, but you have these very high levels of D-dimers. And I think probably the D-dimers reflect urokinase activity in the lung, trying to break down all of those fibrin deposits as part of ARDS. And macrophages themselves will produce urokinase and can break down CLOT2 through other mechanisms. So this is not DIC. It reminds us of the old concepts of what is the point of coagulation. Well, the point of coagulation is to wall off invading bacteria, some would argue. And so if you get inflammation, the final point of inflammation is local clot formation. And we know this in vasculitis clinics, but we don't treat the patients with anticoagulants. We give them an anti-inflammatory, as we did in COVID, and you will see less immunothrombosis. The other factor in COVID in those early patients, we had 200 patients on ventilators in my hospital, was how hypoxic some of them got as they started to die. They did get DIC when they were dying. And we know that hypoxia stimulates a prothrombotic state by binding to the HIF gene, and it will cause upregulation of tissue factor and PI1. So when we go back, the pathogenesis of the coagulopathy that we saw in severe COVID in the early days, and I imagine that they're seeing in China now with Omicron in a population that's fresh to COVID, is this combination of acute phase response, endothelial cell activation, and fibrinolytic shutdown. And this is not DIC. If you are dying of COVID and you're very hypoxic, you will have a DIC. But we're not really seeing this now with Omicron. We very rarely have a patient who requires ventilating with COVID, and we're very rarely seeing VTE because these patients are getting adequate thromboprophylaxis and they don't have such a marked response. Thank you very much.
Is there any questions from the audience for Dr. Hunt? See anybody? Do you have a question? I have a question for you. So you commented on the fact that we are not seeing the same amount of presentation of PE, certainly in the intensive care setting. But even in the emergency department, we've seen a shift, at least in the fully vaccinated individuals. They are not presenting with the thrombosis that we've seen previously. The patients that we see now that present in the ED with thrombosis, either DVT or PE, are either partially vaccinated or unvaccinated. And do you have a comment on these fully vaccinated individuals? Are they somehow developing not only the immunity to COVID, but how is that helping with the thrombosis factor?
So if you look at the vaccinated, as you know, there was vaccine-induced immune thrombosis and thrombocytopenia in about 1 in 50,000 of those that got the AstraZeneca vaccine. But when we look at what the vaccine does, it does cause a very mild inflammatory response. But if you look overall at the data of rates of VTE after vaccination, they are no greater than background rate of VTE. And the other issue is mild COVID. Does mild COVID increase your rate of VTE? It may very, very slightly. So the paper I showed you from Sweden talked about patients who were at home, but we know many patients who are at home probably had moderate COVID, but just refused to come to hospital. And I mean, I was surrounded by doctors who were gasping at home, crawling around on the floor, but wouldn't come into hospital. And some of them had clots. So I think with mild COVID, some of the papers are saying there's no increased rate. So what we're seeing is increased VTE with COVID pneumonia.
Thank you very much.
Thank you.
Thank you very much. So we move to the next speaker, that is Armand Mekontso Dessap from the Hôpital Universitaire Raymond d'Or Créteil, France, and he's going to talk.
You're doing well? Okay.
So you have two? Okay, so where the thrombotic coagulopathy mechanism different. So please stay in 15 minutes, even in 2. Thanks.
Absolutely. So thank you. I'm going to present it with my friend Vincent Labbé. Here, our conflicts of interest, we received grants fees from Leo Pharma, especially for the study we are going to present here. As previously said, the topic of coagulopathy during COVID is complex, with a myriad of manifestations, arterial thrombosis, venous thrombosis, but also localized intravascular coagulation. These features have been evidenced in many observational data concerning the macrovascular thrombosis and also in autopsy studies for the microvascular thrombosis. For example, concerning venous macrothrombosis, you can see here on the left the increased incidence of deep venous thrombosis in non-ICU patients, which is even greater in ICU patients, and on the right, the same increase in pulmonary artery thrombosis in non-ICU and ICU patients. Of note, the incidence depends on the screening, and you can see that when all patients undergo CTPA, the incidence is even greater. In fact, the time course of the disease influences the likelihood of venous macrothrombosis. You can see that in this multivariable analysis, the time from illness onset to hospitalization is an independent factor for venous macrothrombosis, stressing the importance of systematic screening for pulmonary artery thrombosis when you randomize a patient in an anticoagulation trial in this setting, and also the need for a strong screening for this thrombosis after randomization. On the side of the microvascular thrombosis, many autopsy studies, one of the most beautiful is this one, published in the New England, where they observed 9 times more thrombosis in the intra-alveolar septa of lungs as compared to what is observed in influenza. And this was associated with very interesting features of neoangiogenesis. So in face of this increased risk of thrombosis, many scientific societies produced guidelines recommending to move from standard dose prophylactic anticoagulation to high dose or even therapeutic dose, sometimes empirically in some guidelines based on the BMI or the D-dimer level. The aim was on the one side to prevent macrothrombosis, which can be assessed by what we call the net clinical outcome, which is the difference between the reduction in thrombosis and the possible increase in bleeding, and on the other hand, to mitigate organ failure, organ injury progression by reducing microvascular thrombosis by this increased anticoagulation. So here we are going to present the results of studies in the critically ill patients. Many of these studies were multi-platform trials comparing therapeutic dose to a mix of standard dose and high dose prophylactic. And you can see that the effect on microvascular thrombosis is not significant, no reduction of disease duration in these studies. On the side of macrovascular thrombosis, these studies were able to demonstrate that the therapeutic dose, as compared to that mix in the control group, reduced macrovascular thrombosis, but we should stress that there was no systematic screening for pulmonary artery thrombosis in those studies, and there was a trend towards an increased risk of bleeding in these studies, with some patients at high risk of bleed included in those patients. So some trouble concerning the net clinical outcome. Other studies in the critically ill compared high-dose prophylactic to standard dose prophylactic, and in these studies there was no effect on the prevention of macrovascular thrombosis, but less than 5% of patients included in this study, for example, had a CTPA after the randomization. So you can see that there are many drawbacks of current studies. No systematic screening at randomization, sometimes a weak screening after randomization. The control group, which is a mix of high dose and standard dose, and inclusion of patients at high risk of bleed, as, for example, patients with renal failure. And we considered those limitations when drawing the anti-COVID trial that Vincent is going to present to you.
Thanks. Thanks, Armand. Thanks to Isicem for the invitation. So we performed the anti-COVID randomized clinical trial and detailed effect of standard dose prophylactic, high dose prophylactic, and therapeutic anticoagulation in patients with hypoxemic COVID-19 pneumonia. In this open-label trial, French multicenter trial, we compared 3 separate strategies: head-to-head, standard dose, high dose, and therapeutic dose in patients with a systematic screening for pulmonary artery thrombosis at the initial CTPA. And we excluded patients at a high risk of bleed. Our hypothesis were first therapeutic dose and high dose preventive prophylactic anticoagulation decrease mortality and or disease duration as compared with standard dose. And second, therapeutic dose outperforms high dose. Based on death hypothesis, 353 patients were included in order to randomize 300 patients, so 100 per group. Now the study design, we included all consecutive adult hypoxemic COVID-19 pneumonia patients with oxygen support, nasal oxygen support or more. The main exclusion criteria was hospital admission for more than 3 days or ICU admission for more than 3 days, the extreme body weight, and the renal failure. So we performed a systematic initial CTPA to exclude patients with pulmonary artery thrombosis, and in patients with no pulmonary thrombosis, the patients were randomized on the 3 separate strategy: standard dose, high dose, or therapeutic dose for 14 days. The primary outcome, a round composite primary outcome, was all-cause mortality followed by time to clinical improvement, and the main secondary outcome was a net clinical outcome as a composite of thrombosis, bleeding, and death. So now the intervention: standard dose, high dose, twice standard dose, and therapeutic anticoagulation were initiated immediately after randomization for 14 days with a low molecular weight heparin, preferably tenzaparin, with a possible switch on unfraction heparin in case of new onset renal failure after randomization. Now the flow chart of the study, more than 1,000 patients assessed for eligibility. Our main exclusion criteria were extreme body weight and hospital admission for more than 3 days or ICU admission for more than 3 days. So 353 patients were included. Of these patients, 13 patients had a pulmonary embolism, artery thrombosis on initial CTPA, so 339 patients were randomized. Of these patients, 5 were removed, leaving 334 patients in the intention to treat analysis. Now, the results. Baseline characteristics were not significantly different between the 3 groups, with main age approximately 60 years, almost 2/3 men. The main PF ratio was approximately 100 in the 3 groups. 90% of patients were in ICU at randomization, and approximately 60% of patients were on high-flow nasal oxygen. So now the result of the primary outcome. There are no difference regarding the probability of more favorable outcome between the 3 groups, with the results of the individual component of the primary outcome were consistent with the main analysis. Now, the result of our main net clinical and main secondary outcome, the net clinical outcome. Here, this figure represents the cumulative incidence probability of this secondary outcome, with dashed line the standard dose, the solid line, the high dose, and the dotted line, the therapeutic dose. And we can see here that the high dose provided the best net benefit in comparison with the standard dose, driven by a 4-fold reduction in thrombosis as compared with standard dose, with no increase for major bleeding. And second, therapeutic anticoagulation did not have any additional benefit in comparison with high-dose prophylactic anticoagulation. So here's the overlapping number of patients with thrombosis, bleeding, and death, and we can see here the 4-fold reduction, on thrombosis with high-dose prophylactic anticoagulation and therapeutic anticoagulation in comparison with the standard dose. And focus on thrombosis, mainly where pulmonary artery thrombosis, more than 50% of patients had lobar or truncular pulmonary artery thrombosis. The CTPA screening were performed during the study, the follow-up in 21% of patients, with a rate of positive CTPA that was higher in the standard dose in comparison with the high dose and the therapeutic dose. So our study has several limitations. First, the open label methodology with risk of detection bias. However, the rate of positive CTPA significantly higher in the standard dose group than in the high dose and therapeutic group, whereas the rate of negative CTPA was similar in the 3 groups. Second, the relatively small number of patients with a study that was not specifically powered to detect effect size regarding clinical net benefits. And third, the majority of patients had Delta variant, in contrast with previous reports, that may potentially explain the lower mortality rate than expected, that likely impacted the outcomes assessments. And now, the conclusion of the study. First, high dose and therapeutic dose anticoagulation did not improve the primary outcome of death and time to clinical improvement when compared with standard dose. Second, high dose prophylactic anticoagulation provided the best net benefit, driven by a fourfold reduction in de novo thrombosis, mostly pulmonary artery thrombosis, compared with standard dose, with no increase in major bleeding. And third, therapeutic anticoagulation did not provide additional benefit in comparison with high-dose prophylactic anticoagulation.
Thank you very much, Vincent. So 2 take-home messages. If we take the results of this study and the other previous study, maybe the first would be that the role of microvascular thrombosis in worsening local lung injury and organ failure in general may be narrower than previously imagined in this situation with a greater role of macrovascular thrombosis, especially pulmonary artery thrombosis. The second message is that high-dose prophylactic anticoagulation is probably the lowest effective dose able to mitigate thrombosis without increasing the bleeding risk, so providing the best net clinical outcome in these patients. Thank you for your attention.
Excellent. Do we have any questions from the audience? Yes, please. There's a mic behind you.
So there is a mic there. So please use the mic and introduce yourself, please.
Beverley Hunt, thank you very much. Very nicely presented. Can I ask, when you look at your patients, I would imagine that we had quite a lot of obesity because that is a feature of COVID-19 pneumonia. And when you look at your high-dose thromboprophylaxis, is it very similar to the weight-adjusted thromboprophylaxis that we tend to use in the UK? Because you are used to using standard thromboprophylaxis in your standard group. So what is the average BMI is what I'm asking. Thank you.
So we anticipated this problem. That's why we excluded the extreme weight. All patients above 100 kilograms were not included in the study, and this was one of the major exclusion criterion because the other problem that would have induced in the study was probably a complex bleeding risk assessment. So we excluded all extreme weights below 50 and above 100.
You would have not recruited anybody in the UK. That's what I would have said.
Or the US.
I'm afraid to say. Did you do any anti-10A levels to look at the levels of low molecular heparin that you were achieving?
Excuse me,
Did you measure anti-10A activity, which is the effect of your heparin in your patients to see what levels you're achieving?
No, we based our reasoning on clinical practice. In France, when you use low molecular weight heparin, in those with borders, you don't need to monitor it. So we did not monitor it.
But this is a clinical
but we monitored the activity in patients switched to unfractioned heparin in case, for example, of new onset renal failure.
And this is Delta, and I presume they all got systemic steroids and some of them got anti-IL-6 drugs. So it's on that background, isn't it? And so when you talk about microvascular thrombosis, I talk about immunothrombosis. It's the same thing.
Absolutely.
Yeah.
In the discussion of our paper, we stress that the external validity of our finding concerning previous variants is questionable, of course, because this was Delta, not Alpha, and not Omicron, and also the treatment of patients was different with steroids in this case. So all trials in this setting cannot be easily compared due to the effect of variants and therapeutics.
So I have to ask you, now we know Omicron has got a lower thrombotic risk and we have fewer patients going to intensive care. Are you going to use high-dose thromboprophylaxis in that group with that increased risk of bleeding? Or do we need to repeat this study again in the Omicron variant?
A very quick answer, because we need our next speaker.
Repeating the study will be difficult given the lower incidence. So our clinical reasoning is that it seems reasonable, given the absence of increased risk of bleeding with this regimen, to use high-dose prophylaxis. But that's just a projection of these results.
Thank you both, and thank you for the question from the audience. Our next speaker is Tom van der Poel from the Amsterdam UMC, University of Amsterdam, the Center of Experimental and Molecular Medicine, speaking on COVID-19, the role of platelets was interesting. Doctor?
Thank you very much, chairpersons. The title of this session is Comparison Between Sepsis and COVID-19. So let me start by showing you a slide about sepsis and the role of platelets in the procoagulant response in this syndrome. So platelets have been implicated not only in coagulation activation in sepsis, but also in the inflammatory response, and this is primarily through an interaction with other cell types, including the endothelium and neutrophils, with which they form complexes. With regards to coagulation activation, there's abundant evidence that platelets are activated in patients with sepsis, and that they contribute to coagulation activation, for example, by releasing microvesicles that can bind to clotting factors, including tissue factor, which is the main initiator of coagulation activation, and also by expressing phosphorylserine at their surface, which can also assembly coagulation factors at the surface of platelets. And then aggregation of platelets then is very important for thrombus formation. So overall, platelets play a big role in the host response to sepsis, and they are activated. Nonetheless, if you look at all kinds of studies that have been done, not so much randomized clinical trials, but more meta-analyses and other types of observational studies, has not led to the indication of the use of platelet inhibitors as standard of care in patients with sepsis. So there is evidence that platelets are activated, are important for the pathogenesis of sepsis, but platelet inhibitors are not used as standard of care in sepsis. Now let's now switch to COVID-19, and previous speakers have already alluded to the fact that at the start of the pandemic, there was a lot of publicity about the procoagulant phenotype of patients with COVID-19, and hyperactive platelets were considered to play a major role herein. And there were multiple publications to show that platelets are hyperactivated in patients with COVID-19. And this is one of the first papers coming from Wuhan, China, looking at platelet counts that were severely lower in patients that did not survive COVID-19, and also considerably lower, obviously, than normal levels, which is above 150, at least in our hospital, and the induction of thrombocytopenia, or the occurrence of thrombocytopenia, coincided with coagulation activation like fibrinogen consumption, a sign of disseminated intravascular coagulation, and also a rise in D-dimer. Now, there were many studies to show that all of this was associated with platelet activation when you harvested platelets from patients with COVID-19. And not coincidentally, this is a study from our own group by Valentin Leopold. This is patients with COVID-19 on a general ward, so not even critically ill, looking at platelet P-selectin expression, sign of platelet activation, and sure enough, these patients had platelet activation. These platelets were more prone to form complexes with neutrophils, and once complex with neutrophils, these neutrophils were more activated. So if platelets bind to neutrophils, they cause enhanced neutrophil activation. Now, this is just one example. There's many others in the early literature from the COVID pandemic. There's also many papers showing an enhanced platelet aggregation in patients with COVID-19. So this is coming from another group where they compared COVID-19 patients that were not on an ICU versus on the ICU in the blue dots. But sure enough, both of these patients groups showed enhanced platelet aggregation upon ex vivo stimulation with multiple different stimuli as depicted here. So hyperactivated platelets in COVID-19, at least in the early pandemic. Platelets were also considered to be involved in coagulation activation in patients with COVID-19, also early from the pandemic, and this is a tissue factor associated with different cell types in the circulation of patients with COVID-19. And let me focus on platelets because that's the title of this talk. Platelets seem to bind more tissue factor in patients with COVID-19, and there's also papers to show that there's microvesicle platelet-derived microvesicles that express high levels of tissue factor in COVID-19 patients. There's abundant evidence, and this is just one example, also coming from our own group, to show that there's a correlation between thrombocytopenia and the outcome of patients with COVID-19. And the reason why I show this is even true in patients admitted to a general ward. So if your platelet counts are below 150, you have an increased likelihood of dying from COVID-19. And this seems to be a dose-dependent effect because if we stratify further to below 100, there's more effect on mortality. And again, this is patients admitted to a general ward, so this is not critically ill patients. And then this thrombocytopenia is associated with more organ failure, and this is depicted in particular here. So here you see that patients that come in with thrombocytopenia remain thrombocytopenic for the most part. And then this is associated with increased signs of organ damage. And this is independent, so this is a logistic regression analysis and expressed as Hedges-G to express the fold change between patients with normal platelet counts. Now this is coming from later in the pandemic and more recently, and this is also work done by Valentine Leopold, and she extensively looked at platelets during our second, third and fourth wave. So this is when other virus variants kick in and some of these patients have received vaccines. Now if we look at the resting states here, there's now no evidence anymore with enhanced P-selectin expression in the resting state that platelets are hyperactivated in COVID-19, which is also true for other activation markers in the resting state. Now what remains is not on this slide, but phosphatidylserine expression remains elevated on these platelets, and this is a sign of that they don't feel happy, the platelets, and they actually have a procoagulant phenotype. Here below is stimulated, so we took the platelets and we stimulated ex vivo with different kinds of stimuli, as you can see here. And these platelets of COVID-19 patients, all coming from the general ward again, are less stimulatable. And this is across all stimuli and for most of the readouts like P-selectin and CD63 and active GP2B3A expression. And when Valentine then looked at possible underlying mechanisms of this less of reduced stimulatability of platelets with COVID-19, it turned out that they had a strongly reduced mitochondrial function. And this is measured by mitochondrial membrane potential, and this is the resting state, and you can see it's severely reduced in patients with COVID-19. And you also see that there are no change anymore in the membrane potential because it's already so low upon ex vivo stimulation. Now this is not caused to loss of mitochondria because mitochondrial mass is similarly, and we also counted mitochondria by electron microscopy, no differences. So it's a functional difference between patients with COVID-19 and controls. And then we did a metabolomics screen of those platelets to get more insight in what the mechanism might be about this mitochondrial dysfunction and what if we find additional proof of this mitochondrial dysfunction. And sure enough, if you look at the metabolomic screen, the molecules that were most severely downregulated were the energy suppliers, as you can see here. So there seems to be a bioenergetic failure in platelets from patients with COVID-19 that is related to mitochondrial dysfunction. Now, what could be the reason of the discrepancy between the early reports and the later reports, where the early reports all showed hyperactivated platelets, and now we can't find this anymore. And we can suggest that this is due to other virus variants and maybe altered vaccination state. I found this paper last night when I was preparing this lecture, 2 weeks ago, published in the British Journal of Hematology, and you can see that vaccination state, although this may not be selective readout for platelet activation, soluble P-selectin, also derived from endothelial cells, but also from platelets. And you can see that vaccination states influences these levels, and this is also true for platelet-derived microvesicles. So there is a hint that COVID-19, what we call COVID-19, is an emerging, developing disease with the underlying pathophysiology changing. Now, what about treating COVID-19 patients with antiplatelet therapy? And there's multiple trials, and I'm going to summarize them very quickly. And I'm going to go then from mild disease to severe disease. So this is an outpatient trial that aimed to evaluate the use of aspirin for the prevention of disease progression. So patients in the community. The primary outcome, as you can see here, was major thrombosis, hospitalization, or death. And here you see them split out in this table. There was no difference whatsoever. So aspirin does not influence this. Then the next, these are hospitalized patients. And this is comparing a combination of a 10A inhibitor plus aspirin versus control. And here these were patients that were hospitalized, and the aim was to prevent disease progression. And these were the major outcomes. Here also a composite endpoint. There was no difference whatsoever, and you can see here the split off of all of these endpoints. Then we go to patients already in the hospital, non-critically ill, with a P2Y12 inhibitor, so mainly clopidogrel. And this is coming from the platform trial here. And you've seen this scheme in the presentation by John Marshall. So if you die within the first 24 days, you receive a -1. And then the primary endpoint is organ support-free days. So the bluer you are, the more organ support-free days you have. So if you're blue, you're okay. If you're red, you're basically not so okay. There's no difference with the use of P2Y12 inhibitor in this non-critically ill population. And also aspirin in the COVID-19 study done in the recovery trial did not have a major impact on the outcome. These were patients hospitalized for COVID-19. There was a very small benefit discharge alive within 28 days. It's only 1%, and it's questionable whether this is clinically relevant at this time. Then going to critically ill patients. So this is coming from the REMAP-CAP. Where they studied 2 types of platelet inhibitors, aspirin and P2Y12. Data were the same, so they pooled the antiplatelet therapy data, and basically there was no difference in the outcome. This is again the outcome that I've shown you before. So these are if you're red, you're not so okay. If you're blue, you're okay. And there's no difference between the groups. And you can also see that the aspirin and the P2Y12 inhibition does not make a difference. And then finally, this is sort of a similar trial with clopidogrel in critically ill patients with a composite endpoint. And there's no difference in this critically ill population between clopidogrel and no clopidogrel. So in summary, if you look then at the treatment guidelines that you can find on multiple sites, this is from the NIH, chronic antiplatelet therapy, you can just continue if patients receive that for other reasons, but there's a recommendation against the use of antiplatelet therapy in patients with COVID-19. Although most of these trials were generated in the early era, with still the alpha variant and not so many patients vaccinated. So in conclusion, what I've showed you, that the hyperactivated phenotype of platelets that was described early in the pandemic is not so clear anymore in more recent studies. This may have to do with altered virus variants and vaccination state. But still you can see that platelets display an exhausted phenotype that express procoagulant features, and that this is associated with a profound mitochondrial dysfunction and a bioenergetic failure, and this was done in patients that are not critically ill. And then finally, there have been multiple trials now to show that antiplatelet therapy does not improve relevant clinical outcomes in patients with COVID-19. Thank you very much.
Are there any questions from the audience?
Please.
Tom, excellent talk as usual. So I just wanted to follow up on this issue as to whether or not there is a benefit of aspirin. Aspirin is such a cheap agent, and you're looking for a very, very large treatment effect. So to me, a 1% difference in recovery, if that stood up across 100,000 patients, is actually a huge public health benefit. And particularly in light of the fact that you're also looking at early outcomes. In REMAP-CAP, there was a difference. There were only 2 agents that made a difference in survival at 6 months, and that was IL-6 receptor antagonists and antiplatelet agents. So can you comment on both the time issue and the clinical importance when we're talking about agents that have a good safety profile and they're cheap and readily available?
It's absolutely true what you say. So you have to balance out whether you the data that were generated mainly in the early pandemic, if you would now use that systemically in patients that are admitted now with COVID-19, and you can argue that you should do that. You can argue against it. And what I try to do here is look at guidelines and what people that have with committees and have thought about it extensively, and this is what they come up with. And actually, I don't disagree with this advice, but everything you say is also true.
Thanks.
Thank you very much.
So let's move to the next talk that with the title, "The Metabolic Response Was Quite Different." And I'd like to introduce Elisabeth De Waele, Universitaire Ziekenhuis, Brussels, Belgium, please.
Thank you very much. So we are talking COVID-19 patients, and the question was, was their metabolic response different than other patients in our ICUs? So I'm Elisabeth De Waele from Brussels, Belgium. Those are my disclosures. I perform research together with Belgian government and other partners in the field of metabolism and nutrition. So first of all, why are we interested in this metabolism? Because of course, what our patients are trying to do is to stay alive. So they need to keep their metabolism running. And in this paper, rather recent, where I made a visual, what we know is especially these COVID-19 patients, they're in a situation of hypoxia and inflammation. So what you get is a bioenergetic crisis. And that means that there is a lower ATP content available for those patients and lower protein synthesis. So those patients are not reacting as we are, and they are not as efficient as we are in providing both building blocks and energy to have their metabolism running. So what you need is what the authors state in this paper. You need to individualize, you need to provide protein and energy, and then there is some discussions on ketones, timing, energy load, and protein content. But the focus of this topic is, what about this energy? And especially you as a healthcare practitioner, what are you going to provide to those patients in this severely ill situation? So what you would provide is probably the right amount of nutrition. So I'm not talking about the quality of what you're providing, talking about the quantity. And adequate nutritional therapy is based on the knowledge of the metabolism. The only reason to know the metabolism, or the only possibility, is that when you measure it in an individual patient by a technology called indirect calorimetry. And we now have, finally, let's say, for the ones who already are doing this for many years or decades, we have a meta-analysis and review of almost 1,000 patients that shows if you actually use that number for one individual patient, you will reduce short-term mortality. So actual knowledge of one individual number to target your prescription will change the outcome of your patient. So this is what we do. We do it outside of ICU, we do it inside of ICU. We measure indirect calorimetry in a ventilator or another patient. We get this total energy expenditure of the patient at that time being, and we balance it to the intentional and non-intentional calories that the patient had in, let's say, the last 24 hours, and then from there on you make your prescription. So this is the balance that we make on a daily basis for our patients. This is the way that it has demonstrated to have some benefit for your patient. Now, when we think about metabolism, you could say, okay, we can predict it. You know, those patients are in a hypermetabolic state because they have a high infection ratio and they have a lot of critical illness. Now, in ICU, it is almost impossible to predict as a human being the metabolic status of your patient because there are so many influencers of metabolism. And in our own analysis, we saw, for example, that C-reactive protein was not correlated with the metabolic rate. So this kind of feeling that all of us has, oh, when you're sick, you will be hypermetabolic because you're fighting against the disease and so on. In cancer patients, for example, this is much more obvious. But in ICU, also because of our treatment modalities that interact with metabolism, you cannot predict it. So you can see, for example, the usual suspects, hyperthermia would increase your metabolism and hypothermia would decrease it. When we put our patients asleep, metabolism will go down. When you have a heart rate or burns, it will go up. So a lot of parameters influence metabolism, so it's very difficult to predict it. Now, this is why we were so motivated when the COVID-19 patients came into our unit to actually go and measure. And at a certain time point, really early in the pandemic, for example, in the States, it said, don't do this because you will expose yourself to the virus particles in the ventilated patients and so on. But it were also our dietitians that said, okay, but we don't know how much enteral or parenteral nutrition we should give to the patients, so can you go out there? And it's a little hard to see, but in one of the patients, it's only an example, you could see that the measured value was 2,383 kcal per day, and this was only 67% of the predicted value. The patient on the picture is not the same as the report. The report is a 41 BMI patient, a young patient. So if you would work with body weight or equations, you would largely overfeed this patient, and this is what we could prevent by actually going there and measure and do the measurements. Now, a lot of us did eventually started measuring the metabolism of ventilated COVID-19 patients. And in the beginning, you see publications on 7 patients, 4 patients. In the beginning, there was this report of very hypermetabolic state. When you compare the measured value to the calculated and it's higher, you can define it as a hypermetabolic, 4,000, 4,300. And these were the first reports that we got. But it can be dangerous because this can say like, okay, let's overfeed or let's go very high in calories because apparently that's what the patients need. Then there were larger studies with larger data set, and you can see the energy expenditure going down to 2,000 and so on. Of course, we should express it in kcal per kg of body weight per day, but not all the publication did so. And you can see in the second table, indeed, in those 38 patients that were measured, and it was almost more than 100 occasions, but in 38 patients, you can see the variety, the variation between these measured metabolic rates in a time-dependent way, but also in a BMI or body weight. You can see the difference between the obese and the non-obese of 5 kcal per kg per day. But when you have a 100 kilogram patient, that 500 kcal a day, that's half a bottle of enteral nutrition. So this is clinically relevant because you're going to repeat your error day after day. So this is very important information. We know why, because obese patients most of the time have a high fat mass, which is not very metabolically active compared to lean people who have a lot of muscles and organs that per kilogram of body weight consume a lot more energy than the fat mass. So it makes sense, but you can see the variation. This is a very nice trial where they looked in a patient population, COVID-19, and they took 3 different ways of estimating or measuring the metabolic rate in these patients. And you could see that if you would work in this population on body weight, which was at a certain time point stated 30 kcal per kg per day for a ventilated COVID-19 patient, you would go up to 2,600 kcal on 24 hours. So that's a large bag of PN or a lot of enteral nutrition. When you would do, let's say, second best, when you rely on carbon dioxide measurements, there is a validated way to do so, and you see the formulation there. It would drop in the same patient population to 1,400, so that's more than 1,000 kcal a day. Remember that this one bottle of enteral nutrition or a bag, and you repeat it most of the time for a prolonged period of time, as those are ventilated patients. But when you have the gold standard, being indirect calorimetry, taking into account oxygen consumption and carbon dioxide production, you see that the real value was around 1,500. So this is 1,000 kcal difference from the calculations. So, and in average, in this population, they saw 1,400, and the slide before that I just showed you, it was 3,000. So the data coming back from this patient population is, once again, because we know it, showing and revealing a large variability. So the use of predictive equations may lead to overfeeding was also the conclusion of this study. So I think that we were very eager to measure those patients. We were very motivated, and we got a lot of questions like, what is the mean metabolic rate? How much should we provide? We had doctors and dietitians contacting us and the other centers that would perform the test and say, let's do 20, let's do 25, let's do 30. But we couldn't provide them with an answer because I just show you the results. Here is also other data on this population, and this is an illustration in the first table on the time relationships, where we saw that it evolves over time. And in the Blount-Altman plots, you can see that once again, the errors that you can make can be very little in one patient, but very big in another patient, and the error can go up to 2,000 kcal. If you would be forced to eat 2,000 kcal more than you would need for a prolonged period of time, I don't think you will tolerate and that you will have very positive effects. And the errors also go in both ways, so there is not a single correction factor that you could be using. We observed the same time dependency, and also the team of Paul Wischmeyer in the States, they saw this time evolution, which is once again contra-intuitive, because we thought that patients would be very hypermetabolic in the beginning of the disease when they're actually fighting for their lives. But this was not the case. It was lower than 2,000 kcal. And then around 10 or 15 days, you saw a rise. Now, of course, you have to keep into account a lot of variables, like the treatment modalities, how is the patient evolving, and all those parameters that I showed you. We also discovered a gender difference between male and female, but from literature in metabolism, we know, and we have seen it yesterday in a nutrition session, we know that it's most of the time attributed to the difference in muscle mass between most of female and male patients, where we know once again that this muscle is more active than the fat mass. So comparable data from all over the world, but this idea that we have a one-fit-all situation where we have a COVID-19 patients that will be ventilated and then not be ventilated and then go to the ward, and we have mitochondria, we have a virus, so they're in a hypermetabolic state. It is not true. It doesn't happen. We cannot show it to you. What also happened is that we saw even an effect over the different waves. This illustrates, this is data from our center that I don't publish because it's too, dirty. The second wave, we were almost overwhelmed, so there is a variety, probably also in treatment modalities and so on. So it's just an illustration. Is it a COVID strain? Is it a treatment modalities? There was a mean resting energy expenditure of 2,087 kcal a day, but I will never say, okay, this is a magic number that you should provide to all your patients, because you see the variety and the variability in the measurements that we had. If we would do so, if we would, for example, use the European Society of Clinical Nutrition and Metabolism guidelines, which we do if we cannot perform indirect calorimetry due to some technical reason, well, then we would use 20 to 25. And in this slide, you can see on the green dots, the patients where the measured value actually fell within this 20 to 25 recommendation. And you can see the red dots that are patients that are not within the recommendation. So if we would be feeding our patients to the recommendation, 70% of our predictions would not be correct in an individual patient case. And this is something that we know. We know it from non-COVID-19 patients. We know it from other populations. It has been proven before. So this is important information. And it motivates us, even in this COVID-19 pandemic, and also in the beginning when we were not very well protected, to still go out there and do it, to publish also how can you perform indirect calorimetry in the most safest way, not to bring yourself at risk, but to actually get those numbers so that you can feed your patients. And I think that the data that we gathered here proved us right to choose for that approach. So I would like to almost conclude my talk by giving you two examples. I know these are the lowest grade of evidence that you can ever have, but this shows what happens in our daily practice. And I would like to remind you again, this is a young patient of 21-year-old with a BMI of 41. Like I told you, this was a metabolic rate much lower than we would predict if you would do a calculation, and we actually fed the patient on this number, which is feasible. You can do it with hypercaloric enteral nutrition. You can get a big bag of PN, or like we did, we used a combination of enteral and supplemental parenteral to get up to it, because if you would do actually the 100%, you would be at 4,000 kcal, which is feasible, but kind of a challenge. In the other example here, you could see, and this was a totally different patient with a low BMI, 65 kilogram for 1.78 m. And in this patient, you could see a very high metabolic rate of 3,067 kcal on 24 hours, which was almost 190% of the predicted value. And we actually fed this patient up to 3,000 kcal a day, taking care of non-intentional calories by propofol and so on, so that we wouldn't overfeed the patient. But we see this happening on a daily basis. Of course, sometimes we will have a patient where it's 95% of the predicted value or 104%. And in that patient, you probably shouldn't have done your measurements because the prediction was right. But the thing is that you don't know when it's going to be right and in which patient it's going to be right. So this motivates us because we see it every day. So I think that in conclusion, critically ill COVID-19 patients were not hypermetabolic. We revealed a large variation in this population, as we did before the pandemic in other ventilated or non-ventilated patients in ICU. And we know that when you have this approach and is a patient tailored, when you have a nutritional therapy based on this measured metabolism, you can reduce a short-term mortality. So with that, I thank my team for going in there, taking care of the patients, and also for your attention. Thank you.
Thank you very much for your talk. Any question, any comment from? So let me ask you a question from an infectious disease specialist. So did you find any similarity for the metabolic response between COVID-19 and any other type of infectious disease that you find in the ICU, maybe pneumocystis, ear-of-H pneumonia, or CMV pneumonia, or any other type of diseases? So did you find any similarity?
Well, the similarity that we found is that apparently patients really react differently to the same disease. It is not the disease state that will define the metabolism. It's more how people react to the disease, what is going to be the treatment modality, and how they react to the treatment modalities. So I cannot compare the metabolism of COVID-19 patients with a certain disease, but we find the same variation and the same difference in metabolic reaction to a certain disease. It's the same, for example, when patients are on CRT, on ECMO, we would think on ECMO they're all hypermetabolic. They're not. You see a very large variation between the patients. So that is, I think, the most important message.
So there is a question there, please.
Hi, you advocated...
Could you please tell us your name and your country?
Portland, Oregon, United States. You advocated very strongly for the use of indirect calorimetry because there was a big mismatch between the predicted values. Is there any other way of normalizing to try and estimate somebody's energy requirements rather than, taking their weight into account for people who don't have, that we might use if we don't have access to indirect calorimetry?
Yeah, that's a good question. So first of all, the equations are really shown to be inaccurate with very low predictive values and very low compliance, so we shouldn't do that. The second best is when you are able to measure carbon dioxide, and you can also do it when you have a Fick equation and a central Schwann-Ganz, for example. There's some ways to do it, and this is already much better than the equations. The biggest thing is that it is oxygen consumption, which is the most important parameter in your WARE equation for metabolism. It's 4 times as important as carbon dioxide. So if you have the carbon dioxide and you do the 8.19 times the VCO2, you will have a better estimate. But the golden standard remains oxygen consumption and carbon dioxide. And there are a lot of papers comparing those. So I would say that is second best, but I wouldn't settle for it.
I have a question as well. You showed the slide where, at least in a group, in a cohort, there was the delayed hypermetabolism, and you've also shown that it's very difficult to predict. Why do you think that is in this cohort of patients? Because it's not that typical in other illnesses.
No, well, of course, we should have a look at the circumstances of the patients at that time, where they're, for example, at the end of their ventilation, where they're more awake, or where they're just recuperating and going through some kind of rehabilitation phase. This is a question that is very important. We followed up 50 patients, and there were 15 COVID-19, also after ICU for 28 days, and you could not really see metabolism going up there. So it's still a question, what makes them rise and at what time point. But I'm afraid that if we do the analysis, we will find again a lot of parameters that are influencing, and we cannot bring it back to one single parameter. But it's very important to know because we should know that we will probably have to provide more energy at that time point, but that's also still a question to be answered. If you tailor it or if you go even higher, will it have a benefit for the patient? But we don't have an explication for that. Thank you.
Okay, thank you very much. So, because this is the longest session of the Congress, because it's going to be 3 hours and a half, we are a little bit in advance, but I think we can move to the next presentation because, you know, it's too long, and even if we finish 5 minutes in advance, I think it's good for everybody.
The next presentation is with Can Ince. Was the response to the microcirculation different from the Department of Intensive Care, the Erasmus Medical Center, the Netherlands?
Thank you very much. Thank you very much for the invitation. Excuse my voice, it's talking too much in Brussels. I hope to tell you something about insight into the pathophysiology of COVID and studies that we have done at the Department of Intensive Care in Erasmus Medical Center. I have a declared interest. I am involved in a company called Active Medical, and we have a demonstration here of a device which we have used in many of the studies I will be describing. So first of all, if the question is, what's the difference between sepsis and COVID, we first have to look at the pathophysiology of sepsis and what it really is. And there are a number of phenotypes of sepsis, which is very important. It's a disease of the microcirculation. And the problem with the clinical response to sepsis is that all the drugs being given are targeting the systemic circulation, but the actual disease target is the microcirculation in the parenchymal cells. So everything you can imagine happens during sepsis. They are not detected by systemic variables, systemic hemodynamic variables, and they are not responsive to therapy per se. So, and you can see the problem here by if you are just measuring something here and something there, and you've got all of these organs in parallel with their own microcirculation and tissues, that is quite a task to be able to find out what the correlation is between the two. And that is a fundamental problem which also occurred in COVID. So the players, when we're talking about the microcirculation, really are a large number of different cellular systems which in unison have to work together to be able to achieve the oxygen transport by red blood cells. That's the whole purpose of the cardiovascular system, to ensure, up here, my pointer, yep, there, to ensure that there's sufficient oxygen for substrate in oxidative phosphorylation. So we've got the deformable red blood cells, we've got the endothelial barrier, we've got the heterogeneity in the endothelial cells between the different organ systems. These all have to work together. So if we look at sepsis per se, everything that you can imagine that's bad happens in sepsis. The glycocalyx, which is a gel of about 0.2 micrometers, embedded within there, we've got all of the sensory molecules for the mechanotransduction of the shear stress, and this is what we get for the vasotone. So that's one important issue. But there are also the barrier molecules, the cadherins and adherins associated with maintaining the vascular barrier, as well as other stuff like van Willebrand's factor, all in the glycocalyx. So when COVID first hit us, it was already very, very clear that the endothelial cells, that was a target for the COVID infection. And we saw that initially in this paper, and it was called endothelitis, because there was a lot of issues in histologic studies related to caspase upregulation, so apoptosis, monocyte infiltration, and general issues related to the endothelium cells. And it was then also clear that it's the microcirculation which was really being targeted in COVID. And more people started to say, well, you know, it's the vessels that we're really talking about, that COVID is a vascular insult, specifically in the lungs, and that microcirculatory dysfunction could be a unifying pathological hit for COVID. Now, if we take it now one step back again and look at what we know about sepsis, and all of these studies were done really with sublingual microcirculation measurement. This was a study done by Daniel Talmor and Jean-Louis here in Brussels, that if you look at all in septic shock, if you look at all of the parameters responsible for adverse outcome, whether they be lactates, mean arterial pressure or so, an abnormal microcirculation, defined as a plugged vessels, for example, I will show you images, was the single most sensitive and specific indicator of adverse outcome. And this is a study done in Argentina, that what you basically saw was a reduction here in the flow, and here we see an increasing the heterogeneity. So if you look at the images, you see plugged vessels next to normal vessels. And this was an important phenotype of septic microcirculation, where the non-survivors exhibit decreased perfused capillary density. So there was a lower capillary density, perfused capillary density, and that this was associated with adverse outcome. So this is what a microcirculation underneath the tongue looks like in health. And you can see here the capillaries. Let me see, my pointer doesn't seem to be working very well. But in the middle, you see the capillaries. And you also see that if we look here all the way at the right in the loop, I don't know how I'm going to do this without a pointer. So, if you are a cell here, you're a happy cell, because the distance between the red blood cells and the cell is close. So you've got a good oxygen extraction. But if you're a cell up there, you're an unhappy cell, because the diffusion distance is very long. And that explains what oxygen extraction is at the microcirculation. So it's the density of the perfused vessel. If we look here, you see these white guys there. Those are leukocytes. And in inflammation, they will stick to the vessel wall. Yes, but it doesn't work. Now it's working, yeah. Here. So we've got two functional parameters, the convection and the diffusion. Sorry about the physiology, but it's important to understand what the problem is with oxygen extraction in, this is what sepsis looks like. You see plugged vessels all over, and you see a lot of shunting going on, which explains why systemic variables are very, very poor, because there's oxygen shunting. This is the explanation for reduced oxygen extraction in sepsis. The distances between the cells are too large. So this is the model we have for sepsis in terms of oxygen transport deficits. There are areas that are perfused well, there are areas that are perfused bad, and that explains why you can get a high venous saturation in the presence of lactates and excess CO2. Now, let's go to COVID. So there was already in the beginning an important message being said we should be looking at the microcirculation. So we did. This is a study that we did. Emmanuelle Favaron here in the, sitting here in this conference hall. And we published this in Critical Care Medicine because we got a telephone call from the clinicians, and they said, this is not sepsis, we don't really know what's going on, maybe microcirculation will tell us. And basically, we looked at three different aspects, phenotypes. There was the hemodynamic phenotype, there was the leukocytes, and there were the microthrombi. Let me first take you to the hemodynamic response to COVID, which was by far the most interesting. What we saw was, if we compared to volunteers, that the systemic hematocrit was higher in volunteers than in COVID. But if you looked at the hematocrit in the tissues, it was the other way around. So what happened was the red blood cell mass moved from the systemic circulation to the tissues. Not only that, but the diffusion distances increased in COVID. So that's the functional capillary density, was higher in COVID than in volunteers. So what you saw was the response to the hypoxemia, which was being generated by COVID, was the response to increase oxygen extraction by making sure that there's more red blood cells in the tissues and by ensuring that the diffusion distances were smaller. And we saw that across the board. This is a very extreme example of a case study, but here too, we saw very increased functional capillary density. Normal values are around 20. This was up by 30%. And we've, not only us, but other centers also found this increase in perfused capillaries, in complete contrast to sepsis, by the way, in COVID. And here they also found a relationship with the dimer levels. This particular study found also in comparing the sepsis with the non-sepsis in the group of Sam Hutchinson and King's in London, the same thing was found. So the response of the body was to increase the oxygen extraction capacity. Now, the interesting thing about that was that we are also involved in Everest studies and looking at the response of normal physiology to hypoxia. And interestingly enough, the exact same thing happens in Everest. So when you climb high altitude and you have to deal with hypoxia, you get again the shift of the red blood cells to the microcirculation, an increase in functional capillary density. Even though the cardiac output is going very, very fast, you see also a reduction under normal physiology of the flow. If you look at preterm infants, you also see that at high altitudes, their vascular density is a lot higher. So all of these are pointing to the normal response of the body. And this explained what was the big puzzle at that moment, is how was it possible that we had such a low venous saturation and that a lot of patients were doing rather well with what we would consider pathological levels of saturation. And that was because COVID, unlike sepsis, in the initial stages of the disease, is a single organ sepsis. If you look at it that way, and you say that, okay, that if we would have measured on the lung, we would have seen the same sort of thing as you see in sepsis, but that the rest of the organs are relatively in the beginning phase unaffected, that the regulatory adaptive response that the body has to hypoxemia is still intact. But the heterogeneity was very, very clear. And during the progress of the pandemic, we of course started to give dexamethasone and a lot of other stuff, which was making, as physiologists, the story a bit more difficult. This is one COVID patient. This is another COVID patient. And this is another COVID patient. So this patient died, but you saw that there was a very, very large variability. So this is Abele Donati, and they basically also found the same thing in Ancona in Italy, and they also were able to show a correlation between the D-dimer levels and inversion. So what happened with the inflammatory component? Well, here you actually see microaggregates occurring in COVID. These sort of bundles of red blood cells. Now, we don't see that in sepsis, even though we know that the coagulation system is very abnormal. You don't see black snowballs in the microcirculation. Actually, the only time we've ever seen it is, I don't know if I've got the slide on that, I don't think so. But the one thing that we are able to do is to actually quantify their presence, and indeed there were more microaggregates, which is a very, very abnormal thing to see in patients. The only time we really saw it was in patients who were being given protamine at the end of cardiac surgery, too much. And then you saw the same sort of thing. And that's what was done in this particular case study, which we demonstrated. Then the leukocytes. This is a normal volunteer. And here you see all these leukocytes all over the place. And we were also able to quantify those by a methodology which we had developed. And indeed, in COVID-2, you saw a lot of leukocytes. So that's the difference between the hypoxic response and the COVID response, is you also saw the presence of inflammation. Then there's the glycocalyx. Well, there's conflicting results about what's going on with the glycocalyx. There are studies showing that there's glycocalyx shedding products like heparin sulfate and sinecan-1, but other studies which have really shown much less. And in sepsis, there always is a shedding of the glycocalyx. Interestingly enough, if we look at red blood cell function, also something that is of interest, in sepsis we know that the red blood cells get stiff and sticky, not so in COVID. There was relatively little problems with red blood cell function, as shown in this study by Michael Pegnarilli. So this responsive, these are my last number of slides, this response, this adaptive response to hypoxemia was only present up to SOFA scores of 10. So once you had really excessive organ failure, our idea was that all the other organs and endothelial cells were also dysfunctional, and that the adaptive mechanism was not able to recruit the microcirculation as it does in less severe. The leukocytes, however, and the microaggregates, they remain constant. And then we did a follow-up study, because during this time now, we were giving IL-6 inhibitors, and we were giving dexamethasone. So this is from a pathophysiological point of view, a big change. It's a different disease, basically. So we redid a study. This was done in collaboration with a group in Leiden. And we saw, actually, that in the lower SOFA scores now, there was also this lack of adaptive response, and that the SOFA window in this study was from 7 on up. So in the window of 7 to 10 SOFA, we saw the presence of this adaptive response. So my conclusions, ladies and gentlemen, is that viral infections targets the lungs very specifically, as opposed to bacterial sepsis, which I think is more of a systemic story. The infections indeed causes inflammation and coagulation. You can see this direct at the bedside at a point of care method by looking at the microcirculation. The microcirculation increasing the oxygen extraction capacity, and how the body deals with oxygen extraction is key to understanding the cardiovascular response to infection, shock, and fluids, and a lot of other things. And this was, of course, in the VO2, DO2 days. We talked a lot about oxygen extraction. Now no one's interested in oxygen anymore for some reason. And it does so by increasing the density of the perfusion vessels to increase the oxygen extraction. You see in the heart, for example, a lot more closely knit microcirculatory than, for example, the liver, because it's a high oxygen consuming organ. The interesting thing was this shift of the red blood cell mass from the systemic circulation to the microcirculation, and that this adaptive response to hypoxemia is also seen at high altitude, and but is not present in high SOFA scores or in low SOFA scores. Thank you very much for your attention.
Is there any question from the audience? A quick question for you, since time is a little tight. You commented about the happy hypoxic, which was one of the major stressors in the emergency department. These patients would look so well, and you'd put a pulse ox on them, and it would be 70 or 80%. And you showed the 3 different pictures, and you commented on the last one that that patient had died with a very poor microcirculation. Was there any correlation with what you saw? You said that you could tell with the happy hypoxics, but then who would then go on to die looking at their microcirculation? And many of those happy hypoxics did quite fine with a little bit of oxygen and proning them. Were you able to tell by looking at the microcirculation? That last one was pretty obvious, but how about the rest of them?
Well, that's a difficult question. I think the presence of, we've been also had case studies, we've been looking at long COVID too. The response, the adaptive response is a good thing, because it does mean that the adaptive mechanisms are still intact. I think if you find indications of hypoxia without a vascular response to that hypoxia, then you're on the slippery slope. Because also, if that's in association with high amounts of leukocytes, then I think you're in a difficult scenario.
Oh, and we have a question.
Thank
Quick.
you very much. Firstly, well, my question is regarding endothelium surface layer on glycocalyx, because it's slightly different. I'm not sure you can see endothelium surface layer with your device. I think you could not. But in bacterial sepsis, damage of endothelium surface layer is very important. Is that the same things in COVID, especially in the lung? And did there are something linked with coagulation? I do not know link between endothelium surface layer and coagulation.
That's a very important question. This is my take on the glycocalyx. The glycocalyx get degraded in everything you do in intensive care medicine. I mean, one of the easiest ways of degrading the glycocalyx is by giving fluids. And this is really a very important aspect, because if you don't have the glycocalyx, you lose autoregulation. So that's point one. In terms of what happens in sepsis and what happens in COVID, I think it's more beneficial to look at the endothelial cells as a continuum. Because what really is the pathological hit to the endothelium cells is not so much the glycocalyx, which has got a number of phenotypes which are important, among which are coagulation, but are the cadherins and adherins, which are the actual connecting molecules between the different endothelial cells. And you can measure those in plasma as a biomarker. If those loose, then you get leakage of albumin, and that's the real vascular barrier. So there's this paradigm among glycocalyx people that says that it's the reason that there is a vascular barrier. This is not correct. We've done 4 papers and published them. You can get glycocalyx shedding without getting any vascular leakage. So that's point one. In regard to the response to COVID, as I showed you, there are 2 different studies. So I think what's very determined in that is at what stage of the disease you are actually measuring these valuables, and they can be right at the beginning, or they can be after fluid resuscitation and a lot of other stuff. So I think it's time dependent and pathology dependent. There's no general statement that can be made about that.
Thank you very much, Tom. So we can move now to the next talk. I invite my friend Pedro Povoa from University of Lisbon in Portugal, and he's going to talk about was the risk of ventilator-associated pneumonia particularly high? Please, Pedro.
Thank you very much for the kind presentation, for the invitation to be here. So I will try to answer this question in the next 15 minutes or so. These are my disclosures. What I'm going to present to you is a little bit of an overview of the VAP mechanism and also VAP incidence, a little bit of what was COVID, and then the VAP in COVID and some risk factors for VAP in pre-pandemic and pandemic. So VAP, you all know, that is a very frequent disease in patients that are under mechanical ventilation for more than 2 days. The incidence is quite different between the US and Europe, maybe related to some classification issues, but we also know that it's higher in cancer patients and in trauma. That the incidence peaks by more or less the end of the first week of mechanical ventilation, but with variations according to the definition and the sampling procedures. The mortality of these patients could be as high as 50%, but the attributable mortality is not that high. There's a French study that assessed this very carefully, and probably the attributable mortality is much, much lower. And the pathogens are the usual ones that you all know, the gram-negatives, Pseudomonas, E. coli, Klebsiella, Acinetobacter, and also some gram-positives like Staph aureus. COVID changed a little bit our treatment of, not the treatment, but incidence of some of these diseases. There was much more patients with acute respiratory failure, hypoxemic respiratory failure, more patients going to the ICU under invasive mechanical ventilation with severe ARDS. This was across the globe with extreme pressures in our ICUs, and all of these by itself are risk factors for VAP. So the $1 million question is, was the risk of VAP particularly high in COVID-19 patients? And the first study was done by our group. There was a multinational, a multi-center, multinational study where we collect data during the first wave, assessing patients with COVID and comparing them with historic retrospective collected patients with influenza and with ventilated for non-viral infections. So all of these patients were under invasive mechanical ventilation, and we tried to assess the incidence of ventilator-associated lower respiratory tract infection. And what we found is a much higher incidence of ventilator-associated lower respiratory tract infection. And when we look at VAT and VAP, VAP was significantly higher in patients, I don't know if we can, in patients with COVID-19 comparing with influenza and also comparing with non-viral infections. Other groups look at the same type of patients, COVID versus non-COVID patients, looking at ventilator-associated pneumonia, and they found more or less the same results with higher incidence of VAP in COVID patients comparing to non-COVID patients, and with more or less the usual pathogens. Most VAP occurs by gram-negatives, and MRSA, it was similar in both groups. Another study with comparing again COVID patients with previously non-COVID patients, looking at ventilator-associated lower respiratory infections, also with a higher incidence of these ventilator-associated infection in COVID patients, with a higher rate, but again, the density in this particular study was quite high in non-COVID patients, and they also found that there was an increase in ventilator-associated lower respiratory tract infections from the first to the second wave. And concerning the pathogens, they found in this study that Staph aureus was more common, and they have less common streptopneumonia, Haemophilus influenza, and E. coli. And the final study was a study endorsed by the European Society of Intensive Care Medicine, the Unite COVID, that probably most of you have participated on it. It was a multi-center international observational study, almost 5,000 patients, that was not only on VAP, but on ICU-acquired infections, and they identified that more than half of the patients developed at least one infection. And the most frequent infection was bacterial pneumonia in 44% of the patients, with a higher rate than MDR pathogens. And putting all this data together, so the pooled estimate occurrence of VAP in COVID-19 patients was 45.4%, so quite high rate. So what about the definition or the identification of VAP in COVID-19 patients? This was quite a challenge because it was difficult to differentiate between bacterial colonization and bacterial infection, and the presence of symptoms and imaging were frequently not that helpful. And if we look at the known risk factors pre-pandemic, they are very well known. Long ICU stay, long hospital stay, prolonged mechanical ventilation, ARDS, prone positioning, sedation and neuromuscular blockade, ECMO, immunosuppression or the immune status. And if we look at the COVID, during the COVID pandemic, they are almost all of them also quite present. And if we compare one with the other, we know that during the COVID, the mechanical ventilation was for a longer time. They're much more likely to be prone. ECMO was more frequent. They have, by the disease, an immunosuppressive status. You remember very well the lymphopenia of these patients. And if we look at the T cells and some of these patients present what could be a T cell exhaustion syndrome from the beginning, and with also sustained lymphopenia, with increased markers of exhaustion, like increased expression of PD-1 in CD4 and CD8, and also increased frequency of immune suppression cells, like a marked decrease in HLDR expression in monocytes. And in another study, looking at also for different T cells, they have an increased expression of PD-1 and also of CD19. And if we look at the cytokines, they are peripherally not that well expressed, but in the lung, they have a compartmentalized immunological response. Another problem would be staffing, and we talk lots and lots about the COVID patients, but we forgot to see what happened to the non-COVID patients during the pandemic. This is a Brazilian study with more than 500,000 patients, where they look at the mortality over the years that was decreasing, non-COVID patients, and the use of resources. And during the pandemic, with a decrease in the use of resources, there was a sharp increase in mortality in patients with non-COVID. And so this also could be a limitation of care and problems related to the COVID patients themselves. So there was also no data of the compliance and infection control during the pandemic. There was no reporting and analysis accounting for the standardized infection control. The baseline of VAP in COVID-19 was unknown at the time, and there are people working in our ICUs that were not trained personnel, even in protective equipment. But probably that was not only staffing. There are two interesting studies. One single center study of an ICU in France that was non-inundated during the COVID pandemic, and they have a quite elevated incidence of VAP even if they have no problems of lots of patients. So very high rate in spite of no increase in workload. And another a study also coming from France between the first and the second wave, a single center where they have a very high rate of VAP, but in the first wave they were overcrowded, and in the second wave they were not overcrowded, and the incidence was similar in the first and second wave. And then we also have immunosuppressed drugs. And concerning these drugs, some could have some impact. Baricitinib, probably no major impact. Steroids, there is a potential increase in ICU-acquired infections. IL-6 receptor antagonist, also a potential increase. Convalescent plasma, no impact, but we don't know the combinations of these drugs that we are giving to our patients. So we have several risk factors for VAP in COVID-19 patients. I don't know how to go back, it's here. So long duration of invasive mechanical ventilation, ARDS associated with more proning, more ECMO, altered local and general immune response, and also the drugs that we give to the patients, and also specific pulmonary lesions with much higher inflammation in the lung comparing to systemic inflammation. And there are some ongoing studies that will help us to answer even better this question. So in conclusion, VAP is very frequent complication of severe COVID and is more frequent than in other conditions like influenza. There are several risk factors that have been identified, some related to the disease itself, some related to the duration of invasive mechanical ventilation, and others to the drugs that we give to the patients. And the modified risk factors are not that many. Thank you very much.
So thank you, Pedro. There are questions? Please.
Hello, Pedro. Very nice talk. Quick question. Don't you think that the incidence of VAP is overestimated because of the definition itself? Because in fact, VAP is sharing almost the same criteria than COVID. So have you got a strong opinion on that?
My answer would be that with influenza, we get similar pictures. X-ray pictures is also a viral infection. We have the same problems, and using the same poor diagnostic criteria, the incidence was lower. So what I think it's higher comparing to another viral infection.
Thanks.
So Pedro, any other questions? So it's more regarding the type of bacteria. So did you find any difference in terms of etiology of ventilator-associated pneumonia during the COVID period compared to the previous period? You mentioned MRSA, but what about the gram-negative and non-fermentative? We have an experience in Italy with a new appear of Acinetobacter baumannii during 2020 and early 2021. So did you have the same experience in Portugal or in the other European countries?
From the study we did in the COVAPID, we didn't find any strong difference or big difference between COVID and influenza or non-viral infection patients. I think that it's much more dependent of the country than of the disease, and so the data in some of the studies, they have small differences. Again, I think it is more related to the local ecology than the disease itself.
Okay, any other questions, comments? Okay.
Thank you.
Thank you.
Thank you. Our next speaker will be Daniel Talmor from the Beth Israel Deaconess Medical Center, Harvard, a skeptical look at steroids.
Hi, good morning, everyone. So the topic of the whole session is what we can learn from COVID that applies to sepsis, and the point of my talk is going to be that not very much. So these are my disclosures. And it's worth looking back and seeing what we knew about corticosteroids in influenza and viral pneumonia prior to COVID. And these are 3 studies that were done in H1N1 influenza, and all 3 of these showed no benefit and actual harm due to steroids in H1N1. So no benefit in mortality, some showed an increase in mortality, but there were increased rates of nosocomial bacterial and fungal infections in those who received steroids. The signal was so strong that the Infectious Disease Society of America published strong recommendations that clinicians should not administer corticosteroids in influenza or viral pneumonia. So if I was a Bayesian, my prior would be that we should not give steroids, they don't work. Now, along comes pneumonia, along comes COVID, and of course we were all in a panic, rightly in a panic. I mean, the mortality rate in the United States during the first months of COVID-19 was higher than in World War II. All of our ICUs were battlefields, and we were looking for answers. So we reached back to this old anonymous saying from the ICU that no one should die without getting steroids. Now, the initial experience in China with steroids was that there was a higher case fatality rate, but these were all uncontrolled trials. So random patients in Chinese ICUs were getting steroids, some weren't. Probably sicker patients received steroids, so we couldn't tell. And in those first months, if you recall, we were all calling our friends in China or looking for signals there, trying to understand what we could give. The initial experience with steroids was not positive. When a group of Chinese investigators took all of those random patients who received steroids and then did a case matching series between those who received steroids and those who didn't, they found that the propensity matched cohort of patients who received steroids had higher mortality, less survival. So this was published in November of 2000, but the data was known before then. Now, in July of 2020, so really only 4 months into the pandemic in the West, this was published, the recovery trial out of the United Kingdom, a platform trial testing multiple interventions for COVID-19. They studied 6 milligrams per day of dexamethasone in patients with COVID. 2,200 patients received it, 4,300 were in the control group. They did 28-day follow-up and then published the results. At the time of the publication, there were still a lot of patients in the hospital, so the results of the full cohort weren't actually known. But the signal was that there was a small but significant decrease in mortality in patients who received corticosteroids. So you can see here in the usual care group, there was 25.7% mortality, and in those who received dexamethasone, 22.9%. So about a 3% difference in mortality. So this was published online in July of 2020, and the impact was huge. Looking at the subgroups within the recovery trial, it was very clear that the signal was in those who received invasive mechanical ventilation, those who were on oxygen may or may not have benefited, and those who did not receive oxygen, there was no significant signal for improvement. So the recovery trial clearly showed that you had to be ventilated to benefit. Further subgroup analysis there showed that younger patients did better with COVID-19, with steroids. Younger patients did better with COVID-19 and steroids, and that you had to be sick for 7 days to actually receive the benefit. So when they gave it, what I'm conjecturing is if they gave it early, they didn't know if the patients were really sick, and they were giving it to relatively healthy patients. So the lessons were on invasive mechanical ventilation, younger patients, and those who'd been given a trial of getting better by themselves. Now, unfortunately, recovery has never published subsequent follow-up on these patients. So we have an incomplete cohort of 28-day mortality, and we don't know what happened to these patients afterwards. So it's very difficult to understand what really happened to this cohort. Recovery did one follow-up trial in COVID-19. They randomized patients to 6 milligrams or 12 milligrams of dexamethasone. So they took their data to be that 6 milligrams is now standard of care, and they were comparing the new standard of care, 6 milligrams to 12 milligrams. Now, interestingly, this was in patients who were either on no oxygen or a simple oxygen mask. So the ones who in the original trial hadn't actually benefited from the steroids were now getting that as standard of care. And I can tell you in Massachusetts, where I live, the standard of care was as soon as you showed up in the emergency room, you were getting steroids. So this trial was stopped early for harm in the high-dose group. The mortality difference was significant, 18% versus 12%. This paper's only been published online. We haven't seen the full results, so we don't really know what happened there either. Now, the recovery trial was published in July. In JAMA, 1 month later or a month and a half later, there was a special issue with three trials of steroids in COVID-19. This was the most prominent, the REMAP-CAP, another platform trial. And this trial showed an improvement in organ support-free days among patients who received dexamethasone. And this was a 3-arm trial. There was no dexamethasone, regular dose, and then high-dose dexamethasone. So what they found was that there was no difference in results, and no difference in time to death, length of stay in the ICU, or length of stay in the hospital. There was an improvement in the fixed-dose hydrocortisone group for ventilator support and cardiovascular support. So this study was stopped early because the DSMB read the recovery results and decided to stop the study. And we don't really have a good signal from the REMAP-CAP study. The other 2 studies in that issue, one from France and one from Italy, both stopped early. One did not show a benefit, one showed a benefit. So because of the actions of the data safety monitoring boards, as a result of the REMAP-CAP trial, we really don't know. We don't have a good signal in randomized control trials as to whether steroids work in COVID-19 or not. And this was the editorial in that issue of JAMA, corticosteroids and COVID-19 ARDS, evidence and hope during the pandemic. And I think really the emphasis here was on hope rather than evidence, since all of the trials were stopped early. Now, the Cochrane Library eventually did a large meta-analysis of all the randomized controlled trials of corticosteroids in COVID-19. They found 11 with 8,000 participants. Most of those were from high-income countries, and that's important, and I'll tell you why in a minute. And you can read the conclusions down below. So moderate certainty evidence shows that systemic corticosteroids probably slightly reduce all-cause mortality. So moderate, probably, slightly, we don't know. There's a low certainty of evidence that suggests that there may be a reduction in ventilator-free days. We are unable to adjust for the impact of early deaths on subsequent endpoints, and the findings have limited applicability to inform treatment decisions. So in spite of the big splash of the recovery trial, we really don't know what's happened here. And this is a subsequent meta-analysis published in Isicem. The recovery data, as I mentioned, is not an RCT, so it can't be included here, but the RCTs show perhaps a slight benefit, unclear. So the question is, okay, maybe they don't work. Did they harm anybody? And our previous speaker gave an excellent overview of VAP in COVID-19. These are 3 studies looking at the impact of steroids on VAP in COVID-19, all published in the same issue of Critical Care last year. So the first showed 316 matched patients. They found no improvement in mortality with dexamethasone, but they found an increase in VAP, and patients who developed VAP had increased mortality. So the dexamethasone might not have improved mortality, but the VAP definitely made it worse. The second study out of France, 670 patients, they found that dexamethasone increased mortality at 90 days and had an increased incidence of VAP. So clearly the signal that this wasn't working. And finally, the study by Sara and colleagues in critical care, 545 patients. These investigators did a slightly more sophisticated competing risk analysis, and they found that dexamethasone increased mortality, but it wasn't through VAP. VAP was unchanged in those who received dexamethasone. So the total signal here is that dexamethasone at best doesn't help, at worst harms people, and that harm may be mediated by ventilator-associated pneumonia. Now, these are the complications we can see in the developed world, but are there harms that we didn't measure? So, I work in a department in Boston. I have probably 50 Indian origin physicians in my department, and 5 of them had family members who died of fungal infections during the COVID pandemic. Now, if you recall, there was a severe shortage of oxygen in India. There was no shortage of steroids. So patients were getting steroids as soon as they were diagnosed with COVID-19, actually as soon as they coughed. So these are harms we'll never know, but they weren't measured. We can't really tell if this was an impact of steroids, but you have a gun and you have a dead person, you have to think that they might be related. We finally got some long-term outcomes. So this is long-term outcomes published December of last year. The REMAP CAP, so if you remember, REMAP CAP showed a trend towards organ failure-free days. And the long-term outcomes was there was no difference in mortality or in any difference in health-related quality of life in patients who received steroids. So the only bit of long-term outcome we have is that they don't work. Now, they don't work in everybody, but did they work in some people? And we have a very small signal here. This is a cohort of 580 patients at Columbia University in New York, and they did a latent class analysis to divide patients with COVID-19 into those who had a more inflammatory picture and those who had a less inflammatory picture. And you can see the separation here, class 1, class 2, based on the patient's lab results. So first of all, 3/4 of the patients, 373 out of the cohort, did not have inflammatory COVID. And that there's a large body of evidence that shows that most patients with COVID have a normal IL-6. There's no reason to think that they have a high inflammatory state. We did see those patients, but not everybody. Anyway, they divided the patients into COVID ARDS class 1 and class 2. Class 2 was the hyperinflammatory. They compared that to ARDS, hypo and hyperinflammatory, and they found, similar to ARDS, that if you had high inflammatory COVID, you were more likely to die. Your survival was much worse. And then they looked at the effects of steroids. So in class 1 COVID ARDS, 3/4 of the patients, steroids did not help. In fact, steroids probably slightly increased mortality from 46 to 49%. And it was similar in the hypoinflammatory ARDS. In the hyperinflammatory ones, or class 2 COVID, steroids did have a benefit. So in this study, at least, Columbia University in New York, one of the hardest hit hospitals in the world actually for COVID, steroids helped in about 1/4 of the patients. And it was the patients who were hyperinflammatory and could be identified as hyperinflammatory before giving the steroids. So at least we tried, right? We probably will never know what the effects of steroids are in COVID-19 because the signal is so obscured by the noise. It is probably appropriate in some patients, but we have to look for those patients and be thoughtful about it. It's impossible to know if the harms outweigh the benefits because the harms were never properly described. And there may have been an opportunity cost here. So we may have concentrated on giving steroids and not properly investigated other potential interventions for COVID. So I want to leave a bit of hope. What can we do now? There's almost certainly going to be another pandemic, and I don't know what it'll be and when it'll be, and none of us do, but it would really be smart of us to prepare now. So recovery is a platform trial. That's a great idea, but we have to prepare and refine those platforms to get them ready for the next possible pandemic. We have to develop the ability to rapidly classify patients at the bedside so we can know what subphenotype those patients belong to. We have to define thresholds of evidence that are applicable in a pandemic. So is one non-randomized controlled trial enough to change the entire world's practice around care of the COVID patient? We absolutely have to insist on long-term follow-up because 28-day mortality is not a great outcome for anything. We have to beware of publication bias. So the positive trials get published, the negative ones don't. The positive ones get press releases and are released online. The negative ones go through peer review and may be released a year later. And finally, we have to educate DSMBs. In my opinion, the DSMBs of all of the other subsequent trials that stopped them early did harm to patients. Okay, and they did harm to patients not only in the trial, they probably did harm to patients globally. And I'll just leave you here with this little paradigm from the world of business. Sorry. So there are three things you can do. You can have a fast trial, a cheap trial, and a good trial, okay? And in business, they say you can have two of the three. You can have fast, cheap, or good. Now, recovery was fast, obviously. It was cheap because it was based on existing EHRs, existing protocols, but was it good? Did we really get high-quality evidence from that? And I can give this same talk about every other intervention they tested. So we need to be thinking now about how we improve our platform trials so that we land in this sweet spot of cheap, fast, and good. Thank you very much.
Are there any questions or comments from the audience?
I have a small question. You mentioned the different results related to dexamethasone according to different trials. Do you think the different results are caused by the different population? Because at first, there are seldom patients get vaccination. And by now, later and later, more and more patients or the people get vaccination. And also co-medication, like at first, we only know the steroids, like the dexamethasone, but later we also use the tocilizumab, like anti-interleukin-6 antibody. So will this cause the difference results to the dexamethasone?
So those are all very good questions, and the answer is we'll never know because the trials didn't continue. And there were no subsequent trials looking at effects of co-interventions. So you brought up TOCI and IL-6 inhibitors. That's another example of where they were given to everybody, and we know that many patients had normal IL-6 levels. In fact, most patients. So if you have a normal IL-6 level, does giving TOCI make any sense, or are you just opening yourself up to potential complications? But the short answer is we don't know.
Okay, question, please.
Smith, Portland, Oregon. Thank you for your talk. I was interested in the study you illustrated where steroids seem to be helpful if there was a lot of inflammation, both for ARDS and for COVID. Can you talk more about the criteria used to define that state of inflammation?
Sure, I'm sorry they've taken it away. So it's that's not my study, that's from Columbia University. What they did is they classified patients based on multiple potential mediators and some simple bedside ones like your white blood count, your bicarbonate, your temperature, and others more sophisticated ones that take time, like TNF-alpha and IL-6 and so on. And by looking at the different levels in patients, they can find two, this is called latent class analysis, they can separate the patients into two groups. Now clearly, there's a continuum, but you sort of pick a point at which you divide it into two groups. The challenge with doing this at the bedside, of course, is IL-6 is not a bedside test, or is TNF-alpha, so these were done retrospectively. And I think that one thing we could work on is better bedside diagnostics for use in a pandemic. And I think industry is almost there, not quite there, but identifying these groups earlier. So, is this something we do in the ICU, or can we actually do it in the emergency room and see who's at risk of that further deterioration, who can be treated early? So latent class analysis, I think, holds a lot of hope for finding patients who will respond to specific therapies in the ICU.
Okay, thank you very much. No, we don't have any more time, so we move to the next presentation. It's a pleasure to introduce Bruno François from the Centre Hospitalier Universitaire de Limoges in France. He's going to talk about anti-TREM1 approaches are promising.
Thanks a lot, Matteo. Great pleasure to give this talk about anti-TREM approach. Are they promising? These are my disclosure. My biggest conflict of interest is that I was the principal investigator of the Ince trial, which will be presented later during the talk. I don't know if it's useful, but just to highlight that COVID-19 is something pretty similar in terms of epidemiology than a septic shock, and this is the two leading cause of mortality in the ICU. Few words about TREM1. TREM1 is a universal innate immune amplifier. It's expressed by immune cells, and it's activated in parallel with TLR activation following an infection. And TREM1 activation leads to inflammation, and TREM1 activation or overactivation leads to immune dysregulation with excessive production of cytokines, chemokines, and free radicals. Interestingly, when dosed with both TLR agonist and TREM1 agonist, human monocytes are able to produce huge amount of TNF-alpha. In fact, TREM1 has been TREM1 pathway has been mostly documented in sepsis, in which it is activated following an infection, and this results of endothelial cell activation, leukocyte activation, recruitment, activation of coagulation. And if the sepsis still progress, moving to septic shock, then yes, there is a sort of amplification loop in which TREM1 activation promotes the dysfunction of endothelial cells, leading to hypertension, shock, capillary leakage, together with immune dysregulation and, at the very end, organ dysfunction. So this has been highly documented, and there is a pretty common consensus of the involvement of TREM1 in the pathophysiology of sepsis. Interestingly, there is a soluble marker of the TREM1 pathway activation, which is soluble TREM1, S-TREM1, which is in fact released by the cleavage of TREM1 receptor by proteolysis following exacerbation. And it's a really simple marker that can be easily quantified in the plasma by immunoassay. And there is a really nice, as you can see on the right-hand side of the picture, with a nice correlation with survival. This comes from the Mars cohort from Tom van der Poel, which has an observational cohort, you probably know it. on septic shock, a little more than 100 patients, in which the Strem1 has been measured, and there is a really strong correlation between survival and the amount of Strem. Interestingly, both, and this answer to the title of the session, but TREM1 pathway is activated pretty similarly to what is done in septic shock. Following a SARS-CoV-2 infection, together with the involvement of the engagement of the TLR receptors, there is an activation of the TREM1, and which results in a cytokine release, like I presented before. This comes from a group in Brazil. And this group, this has been done at the very early phase of the pandemic in 2020. Roughly 250 patients in Sao Paulo, and they have measured Strem in all patients admitted and documented with SARS-CoV-2 infection, documented with PCR. And as you can see, even if there is an overlap between groups, there is a pretty interesting difference between the level of Strem and the severity of the COVID when evaluated with the ordinal scale. So with low Strem in the very mild diseases, and with much more elevated level of Strem in the critical patient. This preliminary result from this Brazilian group has been confirmed by a Dutch group in the Netherlands. So there was two parts. One first part was done in France with a small cohort comparing healthy volunteer together with COVID patient, and following this initial somewhere proof of concept cohort, they have done more or less a similar approach than the Brazilian group in 218 patients. And as you can see, again, there is an overlap between groups, but there is a difference which is significant between moderate and severe patients, but also when comparing survivor with non-survivor. And also when looking at a patient with complete thromboembolic events. And interestingly, and this is important to be compared with our result from the essential, the median of the Strem level is roughly a little more than 200 picogram per ml. And last paper showing the prognostic value of Strem, which is a meta-analysis from another Brazilian group. Interestingly, they have taken into consideration not only a COVID trial, but also other viral infection observational cohorts. And in the two groups, this is only the group of the COVID infection, but in the two groups, there is an elevation of Strem in case of infection, showing that this pathway is activated during the SARS-CoV-2 infections. Last thing of interest when looking at the value of the soluble TREM, it's its prognostic value when compared to other biomarker. And as you can see, it's much better than can be CRP, but this is not very surprising. It's even equal to IL-6, and when paying attention to both Strem together with IL-6, there is a pretty nice correlation between the level of those two biomarkers taken together and the survival of the patient. This is a funny representation, but just showing that Strem is nicely correlated with a lot of pro-inflammatory cytokines. This comes from the Brazilian group. In red, it's positive correlation. In blue, it's a negative correlation. But as you can see, there is a lot of positive correlation with pro-inflammatory cytokines. Back to pathophysiology of TREM. And in fact, TREM is activated with a TREM1 ligand, and a peptide has been designed or has been set up that binds specifically to these ligands and that inhibit, in fact, the TREM1 receptor. This has been done in Nancy by an academic group. And this peptide is non-gibbotide. Non-gibbotide has been tested in animal models. This is a humanized murine model with a murine SARS-CoV-2 model in which mice were dosed with non-gibbotide when compared to a control group. And as you can see, there is a significant difference between the, in terms of body weight, in terms of respiratory score, but also in terms of survival. And interestingly, there is a nice correlation with pathologic finding with more of inflammation in the lung in the control group than with when compared to the non-gibbotide, which is the LR12 group. So taking all that together, we, with the InnoTrem company, we have designed the Essential trial, which was a phase 2-3 trial in severe COVID patient. I'm really happy to share those results that has not yet been published. Have recently been submitted for publication. So there were initially two parts. One part for safety, 60 patients, and a second part both for efficacy and safety with an accumulated number of 350 patients. Two groups, placebo and non-gibbotide. Primary endpoint was improvement of the clinical status at day 28 according to the 7-point ordinal scale. And we have predefined isolable TREM group based on the value of STREM above the median. So these are the baseline characteristics, pretty classical for COVID patient. Median of STREM, they are well balanced in the two groups. Median of STREM is roughly 250 picogram per ml. Same number of patients receiving dexamethasone or tocilizumab. Most of patients were receiving high flow, and a third of them were receiving at time of admission invasive mechanical ventilation. So these are the clinical status at day 28. And interestingly, as you can see, there is a different favoring the intervention with non-gibbotide. 11% difference of deaths in the overall population. And when looking at the predefined isolable TREM1 population, the difference is even higher, even if less significant, but because the number are lower with a 16% difference. And when adjusting to the baseline characteristic, this result at day 28 with a reduction of absolute reduction of roughly 20%, favoring the non-gibbotide when compared to placebo. And this is kept also at day 60 with a difference of 15%. And there is no true effect of dexamethasone in the upper part. You have the no dexamethasone two groups of overall population and ISTREM1 population, and in the lower part the dexamethasone groups. Few words about secondary infection. again, a trend favoring the non-gibbotide, knowing that the duration of ventilation was lower in the patient receiving non-gibbotide when compared to placebo. So there is a difference of nearly 10% when considering all infection, including VAP, and which go even higher when considering only VAP, with a difference of 13% in all patients and 12% in the high-soluble tremor group. So to conclude, there are now some strong evidence that in most of all critical illness, serious critical infectious illness, there is an involvement of the TREM1 pathway and with immune dysregulation. Similarly to sepsis, TREM1 is activated in COVID, and S-TREM has been confirmed as a good prognostic marker in this specific population and is usable for to do a precision medicine approach. And non-gibbotide treatment results in a significant improvement of the survival at day 28 and decrease of ventilator support when compared to placebo in a COVID-19 population. And it's also safe and well tolerated. And with that, I would like to thank all the other investigators that have contributed, the company, but also the patient and the families that have made that happen. Thanks a lot.
Are there any questions from the audience or comments?
Can I ask a question?
Yes, of course.
Sorry, maybe I missed one slide. Is this new peptide selective targeting the soluble TREM1 or non-selective targeting the cell surface TREM1 and the soluble TREM1 both?
No, soluble TREM is the marker, the biomarker,
yeah.
And the peptide is targeting the ligand.
Oh, okay, ligand. Okay, yeah, sorry.
Any other questions? Thank you very much.
Okay, thanks.
Our next speaker is Jan De Waele from Ghent University Hospital in Ghent, speaking on where secondary infections different.
Thank you very much for the introduction. Difficult question. First thing that pops up is, well, different to what? Different to other viral infections, different to what we usually have. So I'll try to work around the title and discuss the impact of secondary infections, mainly in the difficulties we had and the things we actually learned along the routes. So these are my disclosures, none of them relevant. This is how the Grand Place, maybe some of you have already visited it this year. It looks differently. This is how it looked only 3 years ago from now. Lockdowns in place. We had, of course, big issues in our ICUs. We were confronted with a disease that essentially we did not know very well. We like to compare it to other viral infections and assumed that the co-infection, meaning infection at admission to our ICUs, was a very important thing, and treated these patients as if they had bacterial pneumonia. And many of them received antimicrobials. Now, superinfection or secondary infections are a different thing. Those are the ICU-acquired nosocomial infections, whatever you want to call them, of course often occurring in ventilated patients. So I think it's very important to distinguish these two when it comes to diagnostic strategies and therapeutics as well. But I'll mainly focus on superinfection. Just as a recap, well, we know that the disease has a quite similar course in all of our patients, and bacterial infection was believed to occur especially during the inflammatory response phase from the host, that being the co-infection. And, well, the original reports from China, they actually suggested that COVID was similar to influenza, and that all these patients should be treated with antimicrobials. And indeed, this led us to use a huge amount of antimicrobials in these patients. In most serious, it's between 70 and 95%, which of course will impact the microbiology and a lot of things we do later on. Different antimicrobials were used in this early phase. Again, this is only focusing on co-infection. Quinolones, a lot of variability also, these different colors are from different continents. So clearly, well, we did things quite differently around the world. Now, the diagnosis of infection, whether it was co-infection or secondary infection, was quite challenging. And I'm sure those of you who've been treating patients were well aware of that. It was really very difficult to distinguish the clinical picture of COVID-19 from a bacterial infection, not only at admission, but also probably 7 to 10 days down the road. This hyperinflammation. We actually also had issues in, using our routine diagnostic tools, at least initially, where we were maybe a little bit reluctant to enter patient rooms on regular times, also because there was a lack of PPE, of course. The diagnostic approaches were different, a lot of reluctance initially to sample patients in order to avoid contamination. And imaging, well, really was not very helpful. I mean, these patients all had bilateral infiltrates, which made the diagnosis of secondary pulmonary infections quite challenging. There were some attempts to predict the occurrence of secondary infection. This is just one example. Well, and it's pretty straightforward. The patients who are invasively ventilated, those were at high risk of infections, as well as colonization with carbapenem-resistant Enterobacterialis. Overall, patients stayed longer in the ICU, but from the evidence available, there was no impact on mortality. Biomarkers were also very challenging to use. This is the top level of this figure shows you the PCT and CRP scores in patients with COVID. And again, you will recognize and appreciate the high levels of these biomarkers, again, making it very difficult to diagnose a bacterial superinfection in these patients. At the bottom, you see the performance of PCT and CRP in diagnosing these secondary infections. And you can see actually, indeed, that both for CRP and PCT, you see an increase of infection around the moment of diagnosis. Of course, always the question of the chicken and the egg here, but biomarkers at that point in time seemed promising, although this was largely before the use of the extensive use of corticosteroids and other immunomodulatory agents, which then again made it very difficult to use these biomarkers. So this is the performance, the AOCs, not really useless, but not really very helpful at the same time. So basically, we were navigating blindly. We were just treating patients, trying to use our old paradigms in these new patients, and that was not so easy. Now, when looking back at the things and looking at the literature, it's quite fragmented. And as for many publications when it comes to COVID-19, every hospital, every region actually published their own experience, and it's very hard to use this data and make a strong conclusion. There are a few studies that offer a broader perspective, and I will briefly touch upon those. One of them looked at, was actually a systematic review, and looked at COVID-19 patients, not only in the ICU, but in the hospital at large. And some interesting data there, but of course, no big surprises. For instance, when you look at the prevalence of secondary infections, it's no surprise, as you can see here, that patients in the ICU had the highest number of secondary infections, 42%, which is actually quite high, and higher than you would expect probably in a similar population of critically ill patients. There are some reasons for that, and I'll come to that in a minute, or at least some reasons that I think are relevant. When you look at the types of infections, this is also quite consistent, of course, as in every patient that is ventilated, you will get respiratory infections, but quite striking in this case were actually the high number of bloodstream infections that I'm sure many of you have seen developing in patients. I'll zoom in on that in a minute. Microbiology was Also, well, not surprisingly different when you compare co-infection at admission with the secondary infections in this systematic review. You will see that, well, Staph aureus was an important one at admission and continued to be one at causing secondary infections. But then it's typically, you know, the Acinetobacter, Klebsiella, Pseudomonas, more resistant pathogens that actually cause the infection at a later stage. And again, no big surprise and not really different from what we see in ventilated patients. What were then the predictors? This is a very busy slide. I just want to zoom in on a few characteristics. Again, this study looked at all patients admitted to the hospital. Being admitted in an ICU actually massively increased your likelihood to develop an infection. Female sex actually protected against developing an infection, and mechanical ventilation was also found to increase the risk of secondary infections. So again, quite comparable to what we would see, except for the sex issue, what we see in other patients. The second study I'd like to cite is this secondary analysis of the Isicem COVID-19 Unite project, in which we collected data from over 280 centers around the world. Almost 5,000 patients are included in the analysis. Now, this reflects the situation at the peak wave in 2020, so it's important to keep that in mind. But the occurrence of infection was quite similar to what we've seen. Co-infection at admission was considered to be not very frequent, around 15%, although these patients were treated with antibiotics in most of the cases. ICU-acquired infection later on actually was almost 55%, so a huge number of patients developing secondary infections when admitted to our ICUs. Not really surprisingly, pulmonary infections are ranked first, the majority of them being bacterial, but also fungal infections indeed often reported. Bacteremia, which was not catheter related, third, occurring in almost 1 out of 6 patients, which I think is quite impressive and an important problem in these patients. And other than that, it's the typical other infections, not very frequent, but of course, they are also there. Which factors were associated with the development of ICU-acquired infections in this study? Well, as you can see here, it's about comorbidities, it's about duration, being mechanically ventilated and the duration of mechanical ventilation as well, and the use of other organ supportive measures, as you can see here. Clearly, in this analysis, there was also an impact of steroid use. Not all the patients in the study did receive steroids, and also after propensity correction, then indeed this effect remained there. I know there's other studies that couldn't really confirm this, but we really tried hard to investigate this and did conclude that apparently in this series there was a role or an impact of corticosteroids use. Now, throughout the pandemic, I think in many institutions, multi-drug resistance was an important concern. A lot of these typical characteristics, risk factors for multi-drug resistant infections were present, of course, in patients with COVID-19, prolonged duration of ICU and hospital stay, a lot of antimicrobials being used, especially in the early phase of ICU admission, often patients had comorbidities, elderly patients, and a lot of device use, of course. And this vicious circle, of course, is something that was also highly relevant during COVID-19. A lot of antimicrobial use, a lot of empirical antimicrobials being used, leading to a significant number of patients with multi-drug resistant infections. Now, one of the things that actually really came under duress was the antimicrobial stewardship practices throughout the hospitals, and this led us with co-chair, one of the co-chairs, to write this editorial. And we actually noticed that many, if not all, typical components of antimicrobial stewardship programs in all hospitals actually were ignored during the pandemic. This is just one example, comes from the UK, how COVID-19 impacted antimicrobial stewardship. And you can see, for instance, that there was a positive impact when it came to using technology and new ways to interact with each other. But for all other aspects of stewardship, surveillance of antimicrobial use, education and training, the research, the audits that were done, committee meetings, all of those things actually were negatively impacted. So in this figure, everything that is red is a negative impact in different hospitals throughout the UK. So definitely stewardship was probably not really, was ignored largely. Well, there were no meetings. Everybody was staying at home. There were maybe virtual meetings, but I think by now we appreciate the usefulness of virtual meetings to discuss items like this. And another very important thing, I think, was the lack of PPE, especially in the first months. We were all very concerned with catching the virus ourselves, of course. PPE was not removed when going from one patient to another, and I'm sure that contributed to a lot of outbreaks in a lot of hospitals. Healthcare workers did not change gloves as we would do now, and I think that's a recipe for getting more nosocomial infections. So infection control and prevention was also largely ignored in many ways. And add to that, a lot of hospitals actually had less experienced staff coming into the ICU who were not familiar with the procedures, and again, who were largely focused on not catching the virus themselves. So in conclusion, ladies and gentlemen, bacterial infections were indeed an important problem, probably not so much the co-infections at admissions, although we focused a lot on that and we administered a lot of antimicrobials. The superinfections were the big issue, I think, with bacteremia, an important problem. In some situations underestimated, in others overestimated because of the lack of diagnostic tools, especially when it comes to diagnosing respiratory infections. Diagnosing a bloodstream infection, of course, is quite straightforward. But the high incidence, and especially the way we managed antimicrobial stewardship throughout the pandemic, I think, as well as infection control and prevention, are things to be considered in future pandemics. We should not ignore them like we did this time. With this, I would like to end. I'm happy to take any questions.
So I have a question, Ian. So one of the reasons why we overprescribe antibiotics, at least in the first, in the second wave, was related to the fact that the similarity with flu, we suspect a superinfection or co-infection with staph and strep. However, at the end, we know that the co-infection was lower than 5%. So going back, to what we did, what can we say to the colleagues? Because more than 85% of the cases, community-acquired SARS-CoV-2 infection were treated with azithromycin or cocktail of other antibiotics, and this is one of the reasons why we increase resistance. So if we have to come back, your suggestion is to change something? I mean, looking more at the bacterial co-infection and since the beginning said that there is no reason for using antibiotics, or try to stop the use of the antibiotics more in the hospital acquired infections?
Well, we should definitely learn something from it, and the use of antimicrobials in the early phase is definitely to be considered. I think the early reports did mention the occurrence of bacterial infections. In the end, well, it turned out to be differently in our hospitals, but I think we relied a lot on the initial data coming from China primarily. And of course, we were very afraid in doing a lot of diagnostics, at least in my hospital, and I think this is the same in many other hospitals, like frequent sampling of endotracheal aspirates, et cetera, et cetera. What I think we should learn is that, just act normal and, rely on the things you know and the approaches you've been doing, and don't start changing things radically without solid evidence. We have to admit also that the use of antimicrobials was in the guidelines at some point in time as well. And of course, it's easy to criticize afterwards, but for many aspects, and this relates to the use of ivermectin and all the crazy things that have been proposed, just act normal and do the research before jumping to the conclusions.
So going back to our article, I believe that antimicrobial stewardship was back not to the 90s, but probably to the 80s.
Yeah.
So this is the problem. Yeah. So thank you very much, Jan. So let's move to the last talk. That is, I invite Dr. Carol Hodgson from Monash University, Melbourne, Australia. And she's going to talk about, is the post-COVID syndrome different from PICS? Please.
Thank you, Dr. Bassetti. I've been asked to speak about COVID versus non-COVID post-intensive care syndrome. So to start with, when the pandemic hit in 2020, of course, we were unclear about whether COVID-19 was different to other forms of acute respiratory failure, or ARDS. And in fact, there was questions about low elastance versus high elastance, low recruitability, high recruitability, until there was a call, I think, for a moderate response in terms of just delivering best practice as we know it for acute respiratory failure and ARDS. But I guess the questions that we had around how to manage COVID-19 in intensive care and in hospital translate to, are the outcomes different after hospital discharge for patients with COVID-19? And we know that COVID-19, the disease spectrum is wide-ranging, and the results in symptoms resemble post-intensive care syndrome, but we were unclear if there were specific differences that should be measured or noted, or how our patients might recover. So one of the first publications that came out was from Italy in 2020, and this was a cohort of 143 patients. It only included 5% who were mechanically ventilated, and it was from a single centre. But 60 days after the onset of COVID, 87% of their patients had persistent symptoms, which were primarily fatigue and dyspnea. So that sounded a little bit like post-intensive care syndrome to us. And then from this French cohort that looked at hospitalisation, post-hospitalisation outcomes at 4 months in 177 patients in an outpatient clinic, 97 of those patients had been admitted to ICU. They found that there were abnormalities in CT scans in 75% of patients who'd been intubated, dysfunctional breathing in 21%, and new onset dyspnea in 44%. There was decreased ejection fraction. You can see less than 50% in 10% of their patients, and 51% of their patients reported at least one symptom that did not exist prior to COVID-19. Similarly, in this Belgium follow-up clinic, there was a group of patients who were looked at who had a length of stay greater than 7 days and followed up at 3 months. And they found that 84% had cognitive dysfunction and 75% had sleep disturbances. And I guess this was really alarming because we were starting to worry that maybe COVID-19 would look very different to post-intensive care syndrome, where we know that there's a cognitive burden, but we definitely didn't think that it was as high as 84%. And finally, there was this follow-up study from the same group who looked at 1-year functional decline in COVID and non-COVID-19 critically ill survivors. They had 132 patients with COVID-19 and 88 non-COVID-19 patients. And just to explain that their non-COVID patients was anybody who'd been admitted to the intensive care unit in the same time period. And they found, so for example, that meant that 54% of them had a cardiovascular diagnosis as opposed to a respiratory diagnosis. But they found, as you can see, there was no difference in health-related quality of life at 1 year, and there was no difference in activities of daily living measured with the Bartel Activities of Daily Living score at 1 year. So this made us really question, was COVID-19 just the sort of big hit trajectory of recovery where you have a sudden illness and then you pretty much return, perhaps not quite exactly to baseline, but nearly to baseline? Was this a slow burn where some patients were going to continue to deteriorate and you know, perhaps die down the track? Or was it like a relapsing recurrence where patients with some ongoing respiratory function might be readmitted to the ICU? And to look at some of those, in Australia, we did a prospective cohort study and then we compared it to a cohort study of non-COVID patients that we'd collected data in the 2 years previously. So the aims of our study were to describe new disability and changes in functional outcomes at 6 months in patients who are critically ill with COVID-19 and to compare functional outcomes at 6 months after discharge of mechanically ventilated patients with COVID-19 compared to non-COVID-19. We also looked at a qualitative study where we looked at the experiences of COVID-19 survivors and we also looked at describing the communication and swallowing disorders. So I'll just touch on those briefly, but the main part is the first two. So this was a multi-centre registry embedded prospective cohort study, and it was embedded within our Sprint-SARI registry in Australia, which collected data on all hospitalised COVID-19 patients who were admitted to ICU. COVID-19 and non-COVID-19 patients were from 2 multi-centre prospective cohort studies, the COVID recovery study, which I've shown you the publications, and the PREDICT study, which was published in Intensive Care Medicine with Lisa Higgins as the first author. The ethical approval at participating sites was sought under a waiver of consent for hospital data and an opt-out consent for our follow-up data. So we included adults who were positive for COVID-19 and admitted to an Australian ICU and enrolled in Sprint-SARI because we used all of their data for the baseline hospital outcomes. And for comparison with non-COVID-19, we used patients only on mechanical ventilation for greater than 24 hours who had a diagnosis of acute respiratory failure. So these were only respiratory failure patients. Our exclusion included patients who opted out, who are unable to communicate in English or with a translator, who were living overseas or who were still admitted to hospital. So demographic intervention and hospital data were obtained from the Sprint-SARI registry, and patients who survived to hospital discharge were contacted by telephone. Telephone interviews were conducted by trained assessors who were based centrally at Monash University or by physiotherapists at the site who were trained in outcome assessment. Pre-ICU disability measured with the World Health Organization's Disability Assessment Schedule and health-related quality of life with the EQ5D5L were determined retrospectively at 6 months. So the first aim was to describe new disability and functional changes in patients with COVID-19 at 6 months. And we were able to follow 212 patients, of whom 117 survived and agreed to our follow-up interview. And you can see that the hospital cohort looked similar, I think, to other studies, although please remember that Australia was not overwhelmed. While our system was stretched, we definitely weren't overwhelmed. So I think that some of our outcomes are probably a little better than other places. And in terms of the hospital cohort, you can see that we had 42% had ICU-acquired weakness. The duration of ventilation was 12 days. Hospital length of stay was 16 days. Our hospital mortality was 20%. And we had 56% of patients who had death or new disability at 6 months. So that means that 36% had new disability, where only 20% of patients died. So when we looked at the World Health Organization's Disability Assessment Schedule, so this is the graph at the top, and a higher score means increased disability as opposed to the EQ5D, where a lower score means increased problems with quality of life. So you can see in the top graph that at baseline, our participants had very little baseline disability, and at 6 months they had increased disability. It had, for new disability, we described it as an increase of more than 10%, which is a minimum clinically important difference for the HUDAS in ICU survivors. 36% of patients had new disability, and there was an increase in severity of the disability. Patients also had decreased health status, and an increased proportion of patients reported new problems in all domains of the EQ5D, so mobility, personal care, usual activities, pain, and anxiety and depression. So at 6 months, 70% of our patients reported being fully independent in terms of their activities of daily living despite the degree of disability. 20% had anxiety and depression or PTSD. 33% had cognitive dysfunction. 11% were unemployed due to their health. And older age, frailty and a higher severity of illness were associated with death and new disability. When we compared it to our non-COVID patients with acute respiratory failure, we had 98 patients from the COVID recovery study who were ventilated and 158 patients from our PREDICT study who were mechanically ventilated that we could compare directly. There was absolutely no difference in 6-month survival. However, when we looked at the HUDAS and the EQ5D, you can see that there are some important differences, and these differences aren't at 6 months, they're actually at baseline. So patients who had non-COVID-19 acute respiratory failure had quite a large degree of disability reported in their HUDAS at baseline compared to patients with COVID-19 who were previously had very little disability. And that meant that if you had just compared the 6-month outcomes, if we hadn't measured baseline, you would think that these patients were very similar in terms of the amount of disability at 6 months. However, the amount of new disability is much higher in patients with COVID-19. That is the difference between baseline and 6 months. And similarly, if you look at the EQ5D, in the blue, the non-COVID patients, it looks very similar between baseline and 6 months, whereas the COVID patients had a good health-related quality of life pre-COVID, and they reported a much poorer health-related quality of life. So it's actually the delta, the difference between the two, that is important with patients with COVID-19. Just briefly to touch on the experiences of COVID-19, this hasn't been published yet, but Stuart Lane has completed this study looking at the experience of patients, and you can see that they had a terrible experience from the moment they were diagnosed because, you know, the doctor said, like, hey, she's coming, and they're like, are you the COVID one? And they're like, go out the other door or something. And it was weird because you felt like a leper. And within 30 minutes, the doctor says, you know, you've probably got COVID and you're going to die. And my husband has still not returned to work. He's still suffering from PTSD. He doesn't like it when the phone rings because they used to call him at night to say, you know, she's probably going to die within the hour. So when he hears the phone ring, it scares him. We also looked at communication and swallowing, and this is Amy Freeman-Sanderson, one of our speech pathologists. She looked at swallowing and particularly questioned at 6 months in our survivors, and 100% of our survivors reported communication or swallowing difficulties at 6 months. And she said that the themes included persistent swallowing and communication changes. It affected their participation in community, family and employment, and it changed their social communication. For example, they were unable to communicate empathy or difficulty interacting with their families and peers because their voices were often very quiet and they couldn't interact with them the same way that they normally would, and their tonation was often misunderstood. So the take-home message of COVID-19 versus non-COVID-19 is that there is no difference in the incidence of disability, psychological or cognitive function between COVID and non-COVID acute respiratory failure patients, but in comparison to their pre-illness health status, patients with COVID-19 experienced a larger deterioration, which we would call a big hit. So strategies to reduce both disability and to improve health status after critical illness are crucial for COVID-19 and non-COVID-19 survivors, but I think with particular respect to COVID-19 survivors, we need to think about the impact also on their psychological status, including PTSD, because they were previously very well. Thank you.
Are there any questions from the audience? I have a question about your group that 100% of individuals were found to have difficulty with the swallowing and the communication. Were all of those individuals mechanically ventilated?
Yeah, they were. That was from the cohort that were all mechanically ventilated, and yes, they all reported difficulties with swallowing and speech. And it was very clear that it was both that were involved. There was not a cohort that it was just speech or just swallowing. It was actually both were involved.
Yes, and did they have any ENT studies or anything? Did they look at their
No.
vocal cord dysfunction or anything like that?
No, most of them have been putting up with it, and they, in terms of their other disabilities, it's been something that when they were questioned, they answered, but it hadn't been something that had been reported previously. Yeah, we actually, it was something that was added into this because our speech pathologist was interested in it. We didn't really expect to find that at all, but she's in the process of writing up a paper And there'll be some more work. We've got another cohort looking at persistent critical illness with COVID-19, and she's involved in investigating those patients in a lot more detail.
Thank you very much. Any other questions or comments? Okay. Well, I'd like to thank all of our speakers for excellent presentations. I'd like to thank